For the Bambara groundnut. And why the Bambara groundnut? The Bambara groundnut is actually the underutilized crop still in Indonesia, but this crop has nutritional contents, including carbohydrate 60%, protein 24%, and then the good thing, it has only 6% of fat, so it is very good for diet. And then in Gresik we have 8 of 18 sub-districts which the farmers plant this crop since ages. So actually we have about 100 hectares the potential area for a Bambara groundnut plantation. You know, for this research, actually we need to prove that the Bambara we can plant all the years to get the benefit, not only for food security, but also actually to increase the income for farmers. So in this research, we try to compare maybe 100 pure lines to get the best yield, and then as well as drought tolerance. So we could recommend to the farmers that we could plant this crop all the years. Okay, so this is my students. They're quite busy to collect the data. For example, like to count the number of leaves, and then also the number of flowers, and also the length of canopy, and also the count as well when the pods become mature. So they're doing characterize for Bambara groundnut, not only post-harvesting, but as well as the plant during in the land. So the information is very important because, you know, we have many pure lines that we could provide the information to the researchers.
Welcome to our research site in the fish pond Pangkakulon village, district Ujung Pangka, region Gresik, East Java, Indonesia. I want to introduce myself. My name is Anjar Ahmad Rahim. I am a lecturer in Department of Aquaculture, Faculty of Agriculture, University of Muhamadiyah, Gresik. I want to explain about my research. This is in the fish pond. There is 3 commodities in high value. One of is seaweed. Seaweed is very potential in East Java, especially in district Gresik. In East Java, seaweed price rank from 5,000 until 10,000 rupees per kilo dry it. In 1 hectare, using organic fertilizer with a dose 1.7 ton per hectare. Per hectare seaweed seed stock about 2 tons per hectare in 42 days. Can produce harvest range from 5 until 7 ton of wet. With the ratio of wet and dry weight is 5 wet and 1 dry. Seaweed is very potential. In Indonesia, if utilized to the maximum, it will get big profits. And I hope you will come to us, join us in Department of Aquaculture, Fisheries, and the end of work. Eat fish for good healthy. Thank you very much and best regard.
Ini adalah penelitian tentang uji multilokasi, hasil penelitian untuk mendapatkan varietas unggul tanaman tebu melalui persilangan dari beberapa induk yang mempunyai keunggulan. Oleh karena itu, karena ini sudah 3 tahun, maka kita lakukan uji multilokasi. Salah satunya ada di Gresik, kita sebut di lahan Hollywood. Namanya buka dalam membandingkan, kami juga uji dengan multilokasi tanaman tebu varietas unggul lokal. Di antaranya ada BL maupun JR03. Nah, kita berharap produktivitas hasil persilangan ini bisa menghasilkan produktivitas lebih dari 10 ton, khususnya gula. Dengan demikian, kita bisa melihat nanti hasil persilangan yang kita beri kode klon SB1, SB2, SB3, SB4, dan SB5 ini bisa tahan terhadap lahan kering. Ini bisa kita lihat, misalnya diantaranya adalah klon-klon yang kita coba di lapangan ini, pada lahan kering ini ternyata juga pertumbuhannya sangat baik. Ini bisa kita lihat di sini. Nah, dengan demikian mudah-mudahan ke depan akan kita rubah polanya, itu bukan lagi pola B tetapi adalah pola A. Oleh karena itu bulan Agustus ini akan kita lakukan penebangan atau pengeperasan untuk kita uji dengan pola A, dengan harapan produktivitasnya juga bisa mencapai di atas 10 ton untuk gulanya.
Universitas Nahdlatul Ulama Surabaya atau UNUSA adalah perguruan tinggi yang lahir dari organisasi kemasyarakatan Islam Nahdlatul Ulama. Keberadaannya di bawah naungan Yayasan Rumah Sakit Islam Surabaya atau YARSIS. Diawali pada tahun 1979, berdiri Sekolah Perawat Kesehatan atau SPK, kemudian berturut-turut pada tahun 1985, berdiri Akademi Keperawatan atau Akper, dan pada tahun 1997, SPK menjadi Akademi Kebidanan atau Akbid. Di tahun 2006, dua institusi tersebut melebur menjadi satu institusi, Sekolah Tinggi Ilmu Kesehatan Stikes YARSIS. Berbekal pengalaman lebih dari 33 tahun dalam mengelola institusi pendidikan, khususnya di bidang kesehatan, Maka pada tahun 2013, Tikes berubah menjadi Universitas Nahdlatul Ulama Surabaya atau UNUSA. UNUSA mempunyai visi menjadi lembaga pendidikan tinggi yang terkemuka, unggul, dan profesional dalam ilmu pengetahuan, teknologi, dan seni, berjiwa wirausaha, serta berjati diri Islami. Misi UNUSA adalah melaksanakan pendidikan akademik, profesi, dan vokasi berdasarkan sumber daya dan atmosfer yang kompetitif untuk memacu keinginan belajar, berpikir analitis, kritis, dan inovatif. Melaksanakan penelitian di berbagai bidang keilmuan melalui pemberdayaan sivitas akademika dan mitra kerja untuk mendapatkan inovasi dan keuntungan yang bermanfaat bagi IPTEX. Melaksanakan pengabdian kepada masyarakat di berbagai bidang keilmuan melalui pemberdayaan sivitas akademika dan mitra kerja untuk mendapatkan inovasi dan keuntungan yang bermanfaat bagi kesejahteraan masyarakat. Mengembangkan sumber daya manusia profesional yang mampu menguasai dan menerapkan IPTEX untuk meningkatkan kesejahteraan masyarakat madani dengan pola pikir, sikap, dan tindak tanduk sebagai seorang profesional yang memiliki integritas. Melaksanakan manajemen yang profesional dalam mengelola universitas yang berjati diri Islami, menumbuh kembangkan budaya Ahlus Sunnah wal Jamaah An-Nadiyah dalam kehidupan masyarakat. Saat ini akreditasi institusi UNUSA menyandang predikat B dan hampir semua program studinya sudah terakreditasi B. UNUSA menjadi satu-satunya perguruan tinggi swasta di Jawa Timur yang memiliki program studi magister terapan keperawatan berakreditasi B. Dari tahun ke tahun, peringkat UNUSA terus melejit. Jika pada tahun 2016, UNUSA berada di posisi 2085 dari 3.244 perguruan tinggi se-Indonesia, maka di tahun 2017, UNUSA berada pada posisi 359 dari 3.244 perguruan tinggi se-Indonesia. Dan pada tahun 2018, UNUSA berhasil menduduki peringkat ke-236 dari 2010 perguruan tinggi se-Indonesia. Di akhir 2018, UNUSA dinobatkan oleh Lembaga Layanan Pendidikan Tinggi L2 Dikti, wilayah 7 Jawa Timur sebagai perguruan tinggi swasta baru dengan percepatan pengelolaan terbaik. Di awal tahun 2019, UNUSA berhasil mendapatkan penghargaan bergengsi, predikat perguruan tinggi NU terbaik pertama se-Indonesia, yang diberikan oleh Lembaga Perguruan Tinggi Nahdlatul Ulama LPTNU Indonesia. UNUSA menghadirkan 6 fakultas dengan 20 program studi, Fakultas Kedokteran dengan program studi profesi dokter dan S1 Pendidikan Dokter, Fakultas Kesehatan dengan program studi S1 Ilmu Kesehatan Masyarakat, S1 Gizi, D4 Analis Kesehatan, D4 Kesehatan dan Keselamatan Kerja. Fakultas Keperawatan dan Kebidanan dengan program studi S2 Keperawatan, Profesi Nurse, S1 Keperawatan, D3 Keperawatan, Pendidikan Profesi Bidan, S1 Kebidanan, D3 Kebidanan. Fakultas Keguruan dan Ilmu Pendidikan dengan program studi Pendidikan Profesi Guru, S1 Pendidikan Guru Sekolah Dasar, S1 Pendidikan Guru PAUD, S1 Pendidikan Bahasa Inggris. Fakultas Ekonomi dan Bisnis dengan program studi S1 Akuntansi, S1 Manajemen. Fakultas Teknik dengan program studi S1 Sistem Informasi. UNUSA siap bersaing di era revolusi industri 4.0. UNUSA memahami betapa pentingnya peran teknologi informasi dalam proses pembelajaran di kampus. Oleh karena itu, UNUSA menghadirkan e-Sorogan sebagai media pembelajaran berbasis IT. Teknologi yang dikembangkan UNUSA menjadi kekuatan yang bukan hanya berorientasi pada profit, namun juga berorientasi sosial dan bersandar pada nilai-nilai Islam. Dengan metode pengajaran yang update dan juga modern, UNUSA selalu berusaha mencetak produk akademi yang unggul dan profesional serta berjati diri Islami. Kedepan UNUSA bertekad menjadi kampus terbaik pilihan masyarakat berkelas dunia.
Assalamualaikum warahmatullahi wabarakatuh.
Selamat datang di kampus Universitas Muhamadiyah Tasikmalaya.
Universitas Muhamadiyah Tasikmalaya merupakan perubahan bentuk dari Stikes Muhamadiyah Tasikmalaya yang diresmikan pada tanggal 14 Januari 2015 oleh Ketua Umum Pimpinan Pusat Muhammadiyah, Profesor Dr. Haji Muhammad Din Samsudin, MA.
Ada beberapa fakultas di Universitas Muhamadiyah Tasikmalaya, seperti Fakultas Ilmu Kesehatan, Fakultas Keguruan dan Ilmu Pendidikan, dan juga ada Fakultas Teknik.
Fakultas itu mempunyai fasilitas pendukung yang cukup lengkap, seperti ada beberapa laboratorium, di antaranya laboratorium komputer, laboratorium kebidanan dan keperawatan, laboratorium anatomi, dan ada juga laboratorium lainnya. Kemudian ada masjid yang cukup nyaman. Ada laboratorium skill, perpustakaan, geraha universitas, dan ruang kesenian, serta sarana olahraga lainnya. Untas juga memiliki asrama untuk mahasiswa dan mahasiswi.
Universitas Muhamadiyah Tasikmalaya telah bekerja sama dengan berbagai pihak dan universitas, di antaranya NIIT, National Institute Information of Technology dari India, National Taipei University of Nursing and Health Science dari Taiwan, Institut Teknologi Bandung, PT Dahana Persero, dan dengan perusahaan-perusahaan yang lainnya.
Ada berbagai unit kegiatan mahasiswa, diantaranya UKM Seni, UKM Olahraga, Tapak Suci, Mapala Arundaya, dan banyak lagi lainnya. Mengikuti berbagai kegiatan yang dinamis dan berorganisasi itu penting. Selain untuk mengembangkan diri, menambah banyak teman dan relasi.
Berdiri di Pulau Madura yang kaya akan ragam budaya dan keindahan alam sebagai tonggak untuk mencerdaskan anak bangsa. Universitas Madura didirikan oleh Yayasan Universitas Madura pada tanggal 2 Mei 1978. Unira merupakan salah satu perguruan tinggi swasta di Kabupaten Pamekasan, Madura, Jawa Timur. Universitas Madura yang telah terakreditasi ini terus berkomitmen mengantarkan lulusan dengan mencetak generasi bangsa masa depan yang berkompeten.
Assalamualaikum warahmatullahi wabarakatuh. Selamat datang di Universitas Madura. Universitas Madura telah berdiri sejak 41 tahun yang lalu karena dukungan masyarakat dan telah meluluskan sarjana sebanyak 11.772 orang dari 6 fakultas yang ada di Universitas Madura. Kehadiran Universitas Madura telah memberi kontribusi dan baktinya kepada pemerintah dan masyarakat. Oleh karena itu, mari bergabung di Universitas Madura. Wassalamualaikum warahmatullahi wabarakatuh.
Saya sangat bangga kuliah di Universitas Madura karena tempat yang nyaman dan representatif. Di Universitas Madura terdapat banyak sekali jurusan dan tentunya kalian jika kuliah di Universitas Madura, otomatis kalian akan mendapatkan fasilitas yang sangat dibutuhkan.
Universitas Madura, pilihan bijak masa depan.
Associate Professor Dr. Mazura Mastura Muhammad, the Dean of Faculty of Languages and Communication, University Pendidik, to enjoy our video about our university. Thank you.
Hai, perkenalkan, nama saya Jihan Nawal Aini. Saya merupakan mahasiswa dari Universitas Muhamadiyah Gresik. Universitas Muhamadiyah Gresik atau UMG merupakan universitas swasta yang berada di kota Gresik. UMG juga merupakan universitas terbaik di kota Gresik. Universitas ini berada di Jalan Sumatera, Randuagung, Kecamatan Kebomas, Kabupaten Gresik. Gresik dikenal sebagai kota santri karena di Gresik terdapat dua wali, yaitu Sunan Maulana Malik Ibrahim dan Sunan Giri. Gresik merupakan kota yang kaya akan budaya, mulai dari makanan, tempat wisata, tarian, dan lain sebagainya. Dan di sini saya akan mengangkat salah satu tarian khas kota Gresik, yaitu tarian Giri Solawat. Tarian Giri Solawat merupakan sebuah tarian tradisional dari kota Gresik. Tarian ini menggambarkan proses perjalanan remaja Gresik untuk menapaki kehidupan yang dipanjatkan kepada Nabi Muhammad SAW. Sekian yang dapat saya persembahkan sebagai bentuk perkenalan budaya dari kota Gresik. Dan dengan tarian tradisi, marilah kita mencintai dan melestarikan budaya kita. Terima kasih. Salam budaya.
Bismillahirrahmanirrahim. Assalamualaikum and a very good morning to all. Firstly, I would like to express my sincere gratitude to the organizer for giving me the opportunity to introduce UTM and IPTK in the opening ceremony of the UMG Engineering, Social Science and Health International Online Conference 2020. As the Dean of IPTK, I would like to congratulate the organizer for successfully organizing this conference and personally to Dr. Anida for her participation as a keynote speaker in this conference. A brief introduction about UTM and IPTK. Located in Malacca, which is known as the historical city of Malaysia, UTM is the first technical public university in Malaysia. As a technical focused university, it houses 5 faculties, whereby 3 faculties are in the fields of engineering and ICT, and 1 in technology management. It also has 1 language center and 1 institute, namely the IPTK. The niche area of UTM is advanced manufacturing and computing technology. Thus far, UTM offers undergraduate and postgraduate programs for local and international students in the field of engineering, ICT, management, and social sciences. I would like to inform that IPTK is the only institute in UTM. IPTK stands for Institute of Technology, Management and Entrepreneurship. Embracing the theme Humanizing Technology, IPTK serves to complement the
Universitas Muhamadiyah Gresik's vision is to be the superior and independent university imbued with Islamic entrepreneurship values in 2030, with 3 missions: realistic education, good university governance, and Islamic entrepreneurship. Universitas Muhamadiyah Gresik is very well accredited by the National Higher Education Accreditation Body of certified ISO 9001-3025 by NQA Global Accredited Certification Body. The university has 8 faculties, namely Economy and Business, Teacher Training and Education, Islamic Education, Psychology, Law, Agriculture, Engineering, and Health, with different programs in each faculty. With a total of 35 programs in 2020, Universitas Muhamadiyah Gresik provides education, research, and community service by developing knowledge for the benefit of society. Universitas Muhamadiyah Gresik is also equipped with excellent facilities, including comfortable classrooms, libraries, laboratories, a mosque, a micro-teaching room, a sports center, self-access learning, and more than 50 centers of excellence and expertise. Our best centers are the Center of Incubation and Innovation, the Center of Educators' Professionalism Development, Stock Gallery and Tech Center, Language Learning Development, Business Incubation, Sugarcane Research and Development, Fish and Seaweed Farming, Water Purification, Monosecurity Center, and many others which involve technologies. Those centers support Universitas Muhamadiyah Gresik in offering education at an international standard, promoting virtual or blended learning and collaborating with many partners all over the world. The university successfully runs international programs for joint research, teaching collaboration, visiting lecturers, joint seminars, exchange programs, internships, and community service. With the high quality of teaching, learning, and commitment, we invite students all over the world to experience learning at Universitas Muhamadiyah Gresik.
Excellencies, distinguished guests, participants, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you. The Honorable Rector of the University of Muhamadiyah Gresik and the Vice Rectors, the Excellencies, all the keynote speakers, Mr. Rusli Harisono, MD, MBA, MSc, FAAP from Stanford University, California, Mr. Tito Vivas Mutrago, MD, PhD from Mayo Clinic, Florida, Mr. Nariman Sari Ahmad, PhD from University of Sulaiman, Iraq, Dr. Hasimah Ja'far from University Pendidikan Sultan Idris, Malaysia, Mrs. Pragiwati Pusporini, PhD from University of Muhamadiyah Gresik, Indonesia, the Chairman, the committee, presenters and participants. Good morning, and we are delighted to welcome you to the International Conference Umgeshic 2020 on the title Enhancing Human Resources Productivity in Engineering, Social Science, Health during COVID-19 pandemic, held by the University of Muhamadiyah Gresik through the virtual meeting that will be done in 2 days. It will be started on 9th to 10th December 2020. These conferences are held by the University of Muhamadiyah Gresik in the collaboration with University University of Sulaiman, Iraq, Sultanate of Oman, and sponsored by East Java Television, Radar Gresik, and Santika Hotel. These conferences to bring together academia, researchers, and practitioners who are responsible and interested in developing human resources productivity during COVID-19 pandemic in several backgrounds of studies. These conferences provide a great opportunity for prospective participants to share their recent theoretical knowledge, research findings, and experiences in dealing with sustainable information in enhancing human resources productivity during the COVID-19 pandemic. These conferences will feature presentations by international speakers which are cutting-edge season topics. Excellencies, participants, ladies and gentlemen. Through these occasions, I, as the Master of Ceremony, will read the rundown that covers 2 days' agenda. For day 1, we will start with the opening and welcoming dance. Next is singing the Indonesian National Anthem and Mars Muhammadiyah. Then we have a welcoming speech delivered by the rector. For the second speech, it will be delivered by the Vice Rector of Academic Affairs. And then the season for the keynote speakers, it will be continued to the parallel seasons for the presenters and participants for the economics, engineering, law, and health field of studies. For day 2, we will start with the opening speech by the chairman of the committee, Next is we will have a plenary season with reputable speakers. Then it will be followed by the parallel seasons for the presenters and participants from Islamic study, psychology, agriculture, and education field of studies. And for the last agenda will be closed by the speech from the first academic vice rector. Now, we will have a welcoming dance performance. This traditional dance has a name, Tari Damar Kurung, created by Mas Mundari. Damar Kurung means a light that's shut in a cage. Damar Kurung is the icon of Gresik. It is described the civil culture of Gresik society. Ladies and gentlemen, please welcome the student of Elementary Teacher Education Study Program in Damar Kurung Dance.
Gresik
agenda is singing Indonesian national anthem and continuing with the Mars Muhamadiyah Sang Surya. For all the audience, please stand up. Hadirin mohon berdiri.
Indonesia Raya, merdeka, merdeka.
kembali. Excellencies, participants, ladies and gentlemen, we are now going to listen to the welcoming speech delivered by the Rector of the University of Muhamadiyah Gresik. Please welcome Professor Dr. Setio Budi MSE. We would like to request the Rector to officially open the International Conference Umgeshic 2020.
Assalamualaikum warahmatullahi wabarakatuh. Pertama-tama marilah kita panjatkan puji syukur kepada Allah Subhanahu wa Ta'ala yang Maha Kuasa atas berkahnya telah membimbing kita ke jalan yang benar dan telah memberikan kita semua kesehatan dan kesempatan bersama di sini untuk menghadiri acara yang penuh makna ini. Atas nama Universitas Muhamadiyah Gresik, kami sangat tersanjung dan senang dapat menyambut bapak-bapak dan ibu pada Universitas Muhamadiyah Gresik Engineering, Social, Science and Health International Conference Umgeshic 2020. Kami juga ingin menyampaikan terima kasih kepada semua keynote speaker yang telah menerima undangan kami untuk menjadi pembicara pada konferensi ini. Apresiasi dan rasa terima kasih setinggi-tingginya juga kami sampaikan kepada penyelenggara konferensi, co-host, semua reviewer, serta penulis atas kontribusinya dalam mensukseskan acara Umgeshic 2020. Terima kasih juga pada partner penerbitan kami, IUP Publishing, atas dukungan kolaboratif mereka dalam menerbitkan prosedur konferensi. Tujuan dari Umgeshic 2020 adalah untuk memberikan peluang dalam melakukan penelitian yang nantinya akan dapat diimplementasikan dan dikembangkan dalam kehidupan nyata, mengingat tantangan dalam revolusi industri 4.0, khususnya dalam pengembangan sumber daya manusia serta teknologi informasi. Melalui konferensi internasional ini, kami ingin terlibat dengan Anda semua dalam dialog terbuka dan konstruktif tentang berbagai topik di bidang teknik, sosial, sains, serta kesehatan. Ditambah lagi, wabah pandemi masih juga menjadi isu yang menakutkan bagi hampir semua negara dan mempengaruhi seluruh aspek kehidupan manusia. Oleh karenanya, konferensi ini diharapkan dapat memberikan solusi atas permasalahan yang muncul di saat ini. Hadirin sekalian, akhirnya, izinkanlah saya mengucapkan selamat berkonferensi. Semoga konferensi ini bermanfaat dan menyenangkan bagi kita semua. Semoga acara ini sukses dan membawa lebih banyak ilmu dan manfaat bagi kita di masa yang akan datang. Assalamualaikum warahmatullahi wabarakatuh. Profesor Dr. Insinyur Setio Budi Magister Sains, Rektor Universitas Muhamadiyah Gresik.
For the welcoming speech. The second speech will be delivered by the Vice Rector for Academic Affairs of the University of Muhamadiyah Gresik. Please welcome Dr. Khairul Anwar.
Assalamualaikum warahmatullahi wabarakatuh. Innal hamdalillah nahmaduhu wa nasta'inuhu wa nastaghfiruh wa na'udzu billahi min shururi anfusina wa min sayyiati a'malina. May yahdihillahu fala mudilla lahu wa may yudlil fala hadiya lahu. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadan abduhu wa rasuluh. Amma ba'd. The Honorable Rector, University of Muhamadiyah Gresik, and then the Excellencies, keynote speakers, whether in plenary or in parallel sessions, the Umgeshic committees, the cheerful participants, ladies and gentlemen. First of all, we ought to be indebted to Allah subhanahu wa ta'ala by saying Alhamdulillahi Rabbil Alameen, which in this moment we are still granted the self-determination, enjoyment, and the most important thing is the healthiness during this pandemic of COVID-19. Secondly, on behalf of the University of Muhamadiyah Gresik, needless to say, I am also very grateful for the participation of the ladies and gentlemen as the expert, as the researchers, as the article reviewer, what I mean, and then also the article writers, who are very enthusiastic to participate in this seminar. As we all distinguish that despite this uncertain pandemic breakout, the activities, creativities, and dissemination of scientific knowledge are still in well progress as our responsibility as the academician. For our sincere objective then, University of Muhamadiyah Gresik is initially and also thankfully to facilitate this scientific endeavor, especially to circulate the results of research carried out by industries, research institutions, universities, government, both domestically and internationally, which contribute to the development of human resources of engineering, social science, and health during this pandemic of COVID-19. Which then we briefly say this seminar is called Umgeshic 2020, stand for Universitas Muhamadiyah Gresik Engineering, Social Science and Health International Conference 2020. Third, we are very proud of you all because according to the data that we have already collected in this committee, that there are 344 articles in this seminar, consisting of 121 articles for EST, Engineering, Science and Technology, and 223 articles for each SSH, Health, Science, Social Science and Humanities. Of course, with 26 field of study, that include social science and also exact science, and I also very proud of the participants. I found that at least there are 4 countries joining the seminar: Indonesia, and then Malaysia, and China, Australia, and also the United States of America. So, ladies and gentlemen, surprisingly, I would like to appreciate that there are at least 38 university experts and researchers and also writers joining this seminar. So I feel that this is the first Umgeshic seminar which is carried out in this year. That's the first seminar 2020, and hopefully we will also continue the next year as very proud of a seminar, a very this part of the dissemination place for every researchers and contributors to develop the knowledge, especially the scientific knowledge for exact and social sciences. So ladies and gentlemen, finally, last but not least, I believe that this seminar will run well, and also personally expect that every one of you surely follows the health protocols. And furthermore, I wish all writers, all articles especially, finally and fittingly published in IOP. I think enough for my speech. Congratulations for all and good luck. Fastabiqul khairat, nasru minallah wa fakum qarib. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Khairul Anwar, for the speech. We are now continuing our meeting to the next agenda, that is to hear the keynote speeches. This agenda will be guided by the most beautiful moderator. Please welcome Mrs. Rohmi Husnia. Before coming to the keynote speaker sessions, I would like to inform to all the presenters and participants, please join the whole agenda of this conference till the end of the program in the second day tomorrow. In the order, you can take your e-certificate after completing your attendance and participations. Kepada seluruh presenter dan partisipan, dimohon untuk mengikuti keseluruhan acara dari awal sampai akhir sebagai persyaratan pengunduhan e-sertifikat di akhir acara esok hari. Well, for the moderator, now is your turn to have decisions.
To enhancing human resources productivity through engineering, social science, and health during COVID-19 pandemic. Please remember to mute your audio during the keynote speaker's presentation session. You may unmute it at the discussion session. And thank you for joining today. This is the keynote speaker's presentation session. The questions will come at the end of the session after each presenter speaks. Today, we are going to have two plenary sessions. The first plenary session will be with 2 speakers, and the second one will be with 2 speakers. The 2 speakers for the first plenary sessions are Mr. Rusli Harisano, MD, MBA, MSc, FEED from Stanford University, California, USA. Mr. Tito G. Vivas Puitrago, MD, PhD from Mayo Clinic, Florida, USA. Okay, but before that, I would like to make sure that the 2 respectable speakers already join us. Mr. Rusli Harisano, I'm so sorry, are you here with us? Mr. Rusli? Mr. Tito G. Vivas Puitrago, MD, PhD? Are you here with us? Yeah. Okay, thank you. So, ladies and gentlemen, welcome to the first plenary session today. The 2 speakers will speak in order. Each will have 30 minutes to present, and after all of them speak will be the discussion session for another 30 minutes. Before we listen to Mr. Harisono's presentation, I would like to read his bio. Mr. Rusli Harisono, he is the clinical assistant professor, pediatric critical care. His clinical focus is pediatric critical care medicine, academic assignments, clinical assistant professor, pediatrics critical care, professional education, board certification, Pediatric Critical Care Medicine, American Board of Pediatrics in 2008, Fellowship, Women and Children's Hospital of Buffalo in 2007, New York, Board Certification, Pediatrics, American Board of Pediatrics in 2005, Residency, Brookdale University Hospital and Medical Center in 2004, New York, United States of America, Internship, North Shore University Hospital, 2001, New York. Medical Education, Fakultas Kedokteran Universitas Sumatera Utara in 1993, Indonesia. Okay, so that's his short bio. Mr. Rusli Harisono, good evening. Okay. Yes, Mr. You have 30 minutes to speak. Mr. Rusli Harisono, the time is yours.
Throughout the video, there will be times when we ask you to stop or pause the video and have you enter your responses into a Stanford Qualtrics website. So it would be good right now to launch that Stanford Qualtrics with the link we provided you, so you will be able to provide your responses. Please know these responses are all gathered anonymously, and we will use them to improve the simulations for the future and also know where knowledge gaps may exist.
Let me introduce you to your patient. His name is Elliot Sims. He's a previously healthy 10-month-old baby who weighs 8 kilos. He's presented with a few days of fever and cough, and now admitted to your PICU with acute respiratory distress and hypoxia. His respiratory viral panel was negative, and his COVID-19 testing is pending. He now appears tired, only crying intermittently, and he's on 8 liters high-flow cannula, 100% echo tube with saturations of 94%.
So question one will be, what are any special considerations for intubating a patient with suspected or confirmed COVID-19?
Okay, team, let's prepare to intubate this patient. We're doing a huddle outside the room just to make sure that we're approaching this safely, because intubating a patient with suspected or confirmed COVID-19, we risk aerosolizing droplets virus if we perform manual ventilation. So we're going to deviate from our standard. We're going to plan to do a rapid sequence intubation, connect the patient directly to the ventilator. We're pre-oxygenating him now. And obviously we have to don our PPE, so communication might be a problem too.
Question two, what method would you use to intubate a patient with suspected or confirmed COVID-19?
So we're performing video laryngoscopy instead of direct laryngoscopy. The idea is that we want to keep everybody as far away from the patient's mouth as possible, so we'll be using the video component to guide the placement of the ET tube.
Who are the necessary team members to intubate the patient, and what are their roles?
Okay, I'll be the team leader. I'll take over the intubation and hopefully get that ET tube in. We'll have to decide who else we want in the room, what medications or what equipment.
I'll be the nurse. The patient has a 22-gauge PIV in the AC and the pulse lock, so I think that'll be good.
And then I'll listen to the airway and we can make it straight to the ventilator instead of manual backing. Okay, great. So there'll be 3 of us in the room, and we'll have the rest of our team members outside of the room if we should need help. How are we going to contact them? It's always hard to contact people when we're in here with all of our gear on. If we're going to need other supplies, we're going to need extra help.
Question number 4. After you have entered the patient room, how would you communicate with the rest of the team outside of the room, should you need extra supplies or personnel?
Okay, let's use our mobile phones. We can just call somebody outside of the room and keep on speaker and maybe keep it close to us so that they can hear what we say.
Okay, I'm going to look at the medications and tell me what you have.
Question number 5. What medications will you have in the patient before this rapid sequence intubation? What are the doses for an 8-kilogram infant?
Let's use etomidate and rock. Etomidate's pretty short acting, so the pharmacy can deliver the sedative drips. We'll have those in room so we can get those ready to go. Etomidate dose, let's use 0.4 milligrams per kilo per dose. With microdonium, let's use 1.2 milligrams per kilo per dose. And I think it's helpful to have epinephrine and atropine in the room since we have a baby that will be intubated. The atropine dose will be 0.02 milligrams per kilo per dose, and epinephrine will be 0.01 milligrams per kilo per dose of the 1 to 10,000 formulation. Do we have all the airway supplies that we need?
Question number 6. What respiratory equipment is necessary to intubate a patient with suspected or confirmed COVID-19?
one-way filter, and also an ET tube size 4 and a 3.5. There's a syringe on the porals that we can pick up as soon as it's after intubation. I've also selected the vent, the filters on the inspiratory and the expiratory limb. Since we're putting us right to the ventilator, there might be a little bit of a delay to the end-tidal reading. I've also put the ballard straight on the ventilator so that we can have the line suction ready. And that's it. I'm going to have suction in there, ready to go. Although we're going to try to avoid aerosolic droplets, so we'll try to avoid using suction unless we have to. And we'll try to go down to 0, also the risk of exhalation. And as far as medications, I've drawn up 2 doses of Advil 0.01 milligram per kilogram, 1 dose of Atropine 0.02 milligram per kilogram, 2 doses of Etomidate 0.4 milligram per kilogram, and then 1 dose of 1.2 milligrams per kilogram. And I'm also waiting for fentanyl and Johnson & drips from the pharmacy.
Great idea. The reason I was looking, we should turn that flow down to 0 so that we minimize our risk of aerosolic particle droplets. I'll grab the video where I just we'll take that in and I'll use the video component so that we're staying far away from the patient's airway. And I'll also get oral airway and an LMA in case you run into trouble. I think we're ready to put on our PPE.
Question number 7. What personal protective equipment needs to be worn to intubate a patient with suspected or confirmed COVID-19?
Okay, just to double check, I have the CMAC ready to go with a Miller 1 blade. We'll intubate the patient and I'll pass the ET tube. After I pass the ET tube, will you first inflate the cup, then remove the stylet, and then attach directly to the ventilator? Yes. Great. How are you going to describe the equipment that touches the patient's airway? We don't want to touch anything else in the room, right? Right.
Question number 8. How would you safely discard the equipment that touches the patient's airway and secretions? Specifically, what would you do with the stylet and laryngoscope blade after a successful intubation?
The question, we'll discard all of the equipment that touches the patient's airway into that pink bucket, and then we'll take care of it after we stabilize the patient. Okay, so I'm going to have you take it through when you're ready. I'm going to leave it in the sheet until you're ready for me to hand it to you. I have a 5 syringe that's attached and ready to inflate. As soon as you intubate, then we'll automatically inflate the cup. I'm going to remove the stylet and place it in the pink bucket, and then we will connect directly to the ventilator. Great. Is there any specific way you want me to give the rapid intubation medication? I've never done one before.
Question number 9. How would you direct the administration of medications for a rapid sequence intubation?
Please give etomidate, then rocuronium, then flush. Okay, so etomidate, then rocuronium, then flush. Great. All right, if there are no other objections or questions, I think we should proceed. Okay, we have our phone on speaker, and we have Mark outside of the room. Mark, can you address?
Yes, I can.
Great. All right, so we'll proceed. Lisa, would you mind taking off the high flow nasal cannula and turn the flow to 0, and I will create a tight seal with this mask so we can pre-oxygenate. Flow off, high flow off. All right, I've got a tight seal. Patients are breathing, and we're trying to pre-oxygenate. Ideally, we would do this for a minute or 2. Since he's stable, we'll go ahead and do that. Okay, it's been about a minute and a half, so let's go ahead and give the medication. Please give etomidate, then rocuronium, then flush. Etomidate 0.4 milligrams per kilogram, given. Rocuronium 1.2 milligrams per kilogram, given. And flush. Okay, when he goes after, I'll give you a bag so you can just try the mask. He's after. Have you got please? I see the cord. You're in. Go ahead and inflate the cup. Okay, I'm removing the stomach. Put it in the bucket and connecting straight to the thermometer. Great. And we should be getting it in finally. Okay.
That's the little video short clip on the intubations on the suspected COVID-19 infant. So little introductions, like we all know that is this COVID-19 started back at the end of 2019, and it was declared pandemic by WHO in March 2020. And then now in United States, and then we're seeing the surge again. And then it is an uncharted territory, and then understanding of the illness is keep evolving until today. So children of all ages can get COVID-19. Children appear to be affected less commonly than adults. Shown here is the latest report as of end of November, jointly put out by the American Academy of Pediatrics and Children's Hospital Association in U.S. The overall rate is of 1,777 children's cases per 100,000 children in the population across 49 states, including New York City, D.C., Puerto Rico, and Guam, which is about 12% of total COVID-19 cases. Cumulative death in children as of end of August was 90 deaths, which was about 0.06% of total COVID-19 related deaths, and about 0.02% of total COVID-19 case in children. In California state alone, where I live, the total COVID-19 cases have doubled since August. Last I checked, December 6th, there was more than 150,000 COVID-19 cases in children up to 18-year-old, or about 22.5% of the California population. However, the total death number has not changed. There is a total of 2 deaths in children related to COVID-19 to this date in California. Now, when we talk about the pathogenesis and pathophysiologies of the disease, in the early stage of the disease, viral copy numbers can be high in lower respiratory tract, bronchial epithelial cells, type 1-2 pneumatosis, and capillary endothelial cells. Inflammatory signaling molecules, so-called cytokines, are released by infected cells and alveolar macrophages, in addition to recruited T lymphocyte, monocyte, and neutrophils. These cytokine and killer T cells are meant to recruit other immune cells as well as fight the infected cells. In the later stage of COVID-19 infections, when viral replication accelerates, epithelial-endothelial barrier integrity is compromised. In addition to epithelial cells, SARS coronavirus 2 infects pulmonary capillary endothelial cells, accentuating the inflammatory response and triggering transpulmonary capillary leakage, which leads to influx of monocytes and neutrophils. Also, activations of the kinin-kallikrein system may contribute to worsening disease through bradykinin-dependent lung angioedema, causing further vascular leakage. Now, for knowledge of cytokine response after sepsis, this graphic here on your right shows the normal and abnormal immune response after an infection in salt. Recovery with regaining of the homeostatic balance occur when pro-inflammatory, so that line here, and anti-inflammatory, the blue line here, mediator return back to baseline levels. Early death or fulminant septic shock can occur following early increase innate pro-inflammatory responses, such as cytokine storm, dotted red line here, or after initial adaptive immunosuppression, that's blue line here. Immunoparalysis can occur following early increased adaptive anti-inflammatory responses. Immunosuppression is dotted blue line here. And also after initial pro-inflammatory response, there's a red line here. So much is still unknown about the sudden surge of inflammatory syndrome in younger population in relationship to COVID-19 disease. However, it is well reported that children and adults with intact immune responses, exposure to infection, virus, bacteria, and other microorganisms will trigger the body's cellular immune response to release special chemicals, so-called cytokines. Key cytokines are the pro-inflammatory cytokines such as IL-1, 6, 17, 23, anti-inflammatory cytokines, IL-4, 10, TGF-beta, and the pro-inflammatory cytokines are intended to trigger body response to fight and kill the microorganisms that cause the infections. Unfortunately, human body frequently produces excessive pro-inflammatory cytokines, leading to pro-inflammatory cytokine storm. Human body produces anti-inflammatory cytokines. When these anti-inflammatory cytokines are outbalanced by the pro-inflammatory cytokines, the excessive uncontrolled pro-inflammatory cytokine storm can cause more damage to the remaining of the body cells and organs. The clinical immunological progression suggests that COVID-19 can be divided into three phases. The first phase is a flu-like illness with high viral load, and then the critical phase, which is decreasing viral titers with accelerated inflammatory responses causing lung and end organ injury. And the recovery phase, where the virus titers in nasopharyngeal and endotracheal aspirate specimens are high during first week of symptoms, followed by gradual decline starting at the end of the first week. Most children recover following initial short flu-like illness without progressing to critical phase. From study mostly comprised of adult patients, some but not all studies shows that patients with severe illness had approximately higher viral titers. Patients with more severe disease have less steep and prolonged decline in viral titers, and adult patients with severe COVID have delayed clearance of SARS coronavirus 2. And then the level of inflammatory cytokines are higher in critically ill patients than patients in mild disease. Cytokines including IL-2, 6, and 10, and blood neutrophil counts are significantly elevated in severely ill patients, representing dysfunctional and exacerbated innate response causing lung injury. Number of T-cell, helper T-cell, membrane helper T-cells are decreased, and naive helper T-cell is increased in severe group compared to the milder group. Total lymphocyte CD4 and CD8, T-cell helper T-cell, and memory T-cell counts were significantly lower in severely affected patients, pointing to depressed adaptive immunity. So what are the risk factors? So the bar diagram from CDC COVID-Net shows the underlying medical condition in hospitalized COVID-19 confirmed case. Pediatric here is shown in the light blue bar. Among children hospitalized with COVID-19 from 14 states by August 15, 42% have more than one underlying condition, the most common of which is obesity, and then there was chronic pulmonary disease, and prematurity is about 15% of children less than 2 years old. Children with certain underlying conditions are at greater risk for severe disease, such as they require hospitalizations, they need for intensive care, or they need for mechanical ventilations. Children who are medically complex, who have neurologic, genetic, metabolic conditions, or who have congenital heart disease are also at higher risk for severe COVID-19 than other children. Infants less than a year old, children with immune compromise has been reported associated with severe COVID-19 disease. However, this finding is somewhat inconsistent. These comorbidities associated with severe COVID-19 in patients of all ages. The evidence for the comorbidity listed as established risk factors is more consistent and extensive than that for the comorbidity listed here as possible risk factor. Risk of severe disease also rises steadily with age. So what are the protective factors? As we have all experienced or may have heard that children tend to have fared better than adults when contracted COVID-19 disease. Potential factor protected children against SARS coronavirus 2 infections, the prevention of virus exposure like early isolations and movement restrictions, such as closing schools and daycare centers in epidemics time. And then appropriate infection handling, where children have more trained immunity, strong innate response due to live vaccines given, BCG, live virus vaccines like measles, mumps, rubella, influenza, and frequent virus upper respiratory infection. Children have higher ACE2 expressions metabolizing angiotensin II. Children are lack of immune senescence or age-related immune deficiency, which is typically seen in aging population. Children have good lung regeneration capacity or early lung recovery. Children have greater upper airway resistance with funnel-shaped airway, so aerosol particles deposit more in tracheobronchial tree and alveoli. This could lead to more bronchiolitic-like infections and less pneumonia with the virus infection. Absence of high-risk factors of aging-related comorbidities such as less degree of obesity, heart disease, cerebrovascular diseases. She also noted upregulation of ACE2 in smokers contributes to poor outcome of respiratory infections. It's also not seen in children. So, although severe cases of COVID-19 in children include the fatal cases reported, most children appear to be asymptomatic, mild or moderate disease, and recover within 1 or 2 weeks of disease onset. So here are the percentage of symptoms like of COVID-19 on children. And then, the table here shows the percentage of symptoms related to COVID-19. And then there was a smaller case series has reported sore throat, fatigue, chills, shaking, chills like in adult. GI symptoms may occur without respiratory symptoms, and cutaneous findings were reported not well characterized. Maculopapular, urticarial, vesicular eruptions, transient livedo reticularis, that is purple nodules on distal digits like picture shown here, the COVID toes. Now, when we discuss about COVID-19 disease, we have to talk about this entity, the MISC, and we'll see what it is. So, back in April 2020, reports from UK documented presentations of children similar to incomplete Kawasaki disease or toxic shock syndrome. Since then, there have been many other reports of similarly affected children in other parts of the world. COVID-19 disease in children is actually a clinical spectrum of disease as illustrated by this pyramid here. There may be some overlap between this spectrum. The larger base on the pyramid shows most children with COVID-19 are generally mild or asymptomatic. They typically do not show exaggerated immune response. As the spectrum progresses, from the base to the top of the pyramid, some children may develop a spectrum so-called febrile children with inflammations temporarily associated with SARS coronavirus 2, which is associated with FIS-TS. Children may experience persistent fever, some mild symptoms such as headache, fatigue, and then also inflammatory markers, especially ferritin, may be elevated, but they are lacking signs of multi-system involvement. Then a small proportion of children with COVID-19 may develop more severe spectrum so-called Kawasaki disease, temporarily associated with SARS coronavirus 2. These children meet criteria for complete or incomplete Kawasaki disease but do not develop shock and no multi-system involvement. Very few children may develop the most severe form of the disease spectrum, so-called pediatric inflammatory multisystem syndrome, temporarily associated with SARS coronavirus 2 or shortened with PIMS-TS, or also called MIS-C, multisystem inflammatory syndrome in children. MIS-C. These children have more severe presentation with multi-elevated inflammatory markers, multi-system involvement. Cardiac involvement and shock are common in this subset of children. So these slides show the symptoms of MISC. So common clinical finding with the frequency are shown here in the tables. As MISC is a wide spectrum of disease severity, the clinical sign ranges from milder signs of organ involvement to shock, myocardial involvement, respiratory failure, and other organs failure. Now, shown here in the table are typical laboratory abnormalities with their frequency found in children with multi-inflammatory syndrome. Laboratory markers of inflammations appear to correlate severity of illness. Compared with children, Compared with children without shock, children who developed shock had higher CRP, higher neutrophil count, lower lymphocyte count, lower serum albumin, and more commonly have elevated cardiac markers. Now, finding on diagnostic imaging that include echocardiogram, chest X-ray, chest CT, abdominal ultrasound, or CT, with frequency of the imaging finding are shown in this table. Echographic finding may include depressed LV functions, coronary artery abnormalities that include dilatations or aneurysm, multiple regurgitations, and pericardial effusion. Many children with COVID-19 have normal chest radiographs. As seen here, chest X-ray finding on COVID-19 children may show lower lung joint abnormalities, predominantly consolidations and ground glass opacities. Similarly, most children with COVID-19 have normal CT, chest CT. Some have reported 3 different phases of chest CT that shows in A, B, C here. And then early phase as shown in A, the axial lung window shows a round ground glass opacity pointed by the arrows with some area of central consolidation, so-called the halo signs. Progressive phase of pneumonia is demonstrated by rounded ground glass opacity pointed by the arrows with subtle area of central consolidation between this area, ground glass opacity, the asterisk here, start to fill the lung parenchymal. Developed phase of pneumonia shows predominantly confluent consolidations, so the arrow signs here, in a posterior lower lobe, dependent lobe. Now, WHO and CDC back in May have developed a preliminary case definitions of MIS-C in children. They are pretty much similar. So they have all the 4 criteria has to be met based on the CDC definitions, and all the 6 criteria has to be met based on the WHO definitions. Here's the MIS-C clinical severity classifications at the time of presentation. This classification is somewhat useful to guide us on developing treatment for the patient admitted for multi-system inflammatory syndrome, and then of which we will see later towards its presentations. And then here is the definitions used for organ system involvement on each organs, and then in determining MIS clinical severity classification at the time of presentations. Now, I think I have to discuss a little bit about comparison between the MIS-C with Kawasaki disease. You know, there is a considerable phenotype overlap with MIS-C and Kawasaki disease. For a reminder, the bottom table here shows the diagnosis criteria for Kawasaki disease. In the available case series that we have to date, there are some key difference between the MIS-C and the Kawasaki disease. MIS-C commonly affect older children and adolescents, while classic Kawasaki typically affect infants and young children. MIS-C, Black and Hispanic children appear to be disproportionately affected, and Asian children account for only a small number of cases, while in classic Kawasaki disease, a higher incidence in East Asia and in children of Asian descent. Care for children of COVID-19 that are hospitalized includes supportive care and then the target treatment towards the virus and towards the host response. So the supportive cares are listed here, such as control fever, pain, and then care for pediatric sepsis, severe septic shock if that occur with the early goal-directed therapy, and then fluid and electrolyte support, empiric antibiotics for suspected secondary infections, and then cardiovascular support, the use of vasoactive, vasopressins, inodilators, and then respiratory support, ranging from supplemental oxygens towards mechanical ventilator support, invasive and non-invasive, and then care for other organ support and coagulations, and then perhaps they need an ECMO bypass. Now, this is like we heard pretty frequent, and then clinicians have reported that many adult patients presented with a remarkable disconnect between profound hypoxemia at rest, yet they are without proportional signs of respiratory distress. This is so-called quote-unquote happy hypoxemia and can be falsely reassuring. However, rapid deteriorations can follow pretty fast. So this particular clinical presentation in COVID-19 patients contrast with the experience of physicians usually treating critical care ill patients in respiratory failure, and ensuring time referral to intensive care unit can therefore be very challenging. Pulse oximeter should be interpreted with cautions because left-sided shifting of the oxyhemoglobin dissociates being occurred with COVID-19. Actually, happy or silent hypoxemia is not exclusively seen in COVID-19, but may also occur in patients with atelectasis, intrapulmonary shunt, the right to left intracardiac shunt. The mechanisms of hypoxemia in COVID-19 is shown here in the graphic. The y-axis represents partial pressure oxygen, the s-axis is the time course, and boxes below s-axis are part of management that we can do. And then the arterial hypoxemia early in the COVID-19 infection is primarily caused by VQ mismatch. And there was a loss of lung perfusion regulations, secondary failure of the body to consistently provide protective pulmonary hypoxic pulmonary vascular constriction mechanism. And then this is secondary to the release of endogenous vasodilator, prostaglandin, bradykinin, cytokines associated with inflammatory process, or maybe due to vasoplegia, also shear stress of interfaces between lung structures as part of the patient's self-inflicted lung injury spectrum. And also could be also from dysregulations of the renin-angiotensin system in COVID-19, that diminish of the ACE2, increase in angiotensin 2, stimulate angiotensin 2 receptor, and then pulmonary vasoconstriction. So there was also intravascular microthrombi and endothelial injury in the COVID-19, and then that can actually directly the cytopathic virus can directly infect the lung capillary endothelial cells that express ACE2. And also there was a impaired diffusion capacity where the virus damaged the alveolar tissue cells. So how do you manage this thing is like you do timely but not premature intubations and invasive ventilation support. And then it's maybe that is superior to the non-invasive ventilator in boosting transpulmonary pressure, opening collapsed alveoli, improving oxygenation, decrease oxygen depth, avoiding P-Siley, patient self-inflicted lung injury, and offering a better chance for the lungs to heal. So quality evidence of COVID-19 targeted treatment is generally low. It is important to pay attention to the ratio of risk and benefit of the treatment is the final guidance with the key guiding principle of first do no harm. And then the graphic on the right shows steps in coronavirus applications that are potentially targets for antiviral drug and vaccines. So COVID-19 treatment targeting host response, such as immunomodulatory therapy that includes corticosteroid, immunoglobulin, convalescent plasma, IL-1/6 inhibitors, and then mesenchymal stem cells. So I will go through this treatment very fast for the interest of time. So everybody heard about remdesivir. This is virus targeted treatment. lopinavir combinations of lopinavir with tonavir. It's a started. Lopinavir is for the HIV drug, and then the ribavirin, and then which is like has is a broad spectrum antiviral nucleoside. And then the favipiravir is actually for the oseltamivir resistant flu, and has been used. Now, I think we have to discuss a little bit about the dexamethasone, and then so that is the famous recovery collaborative group trial, and then this was actually in hospitalized patients with confirmed and suspected COVID-19. And then here the Kaplan-Meier survival curves for 28 days mortality among all the patients in the trial primary outcome and in the 3 respiratory support subgroups. Interestingly, that we can see the benefit of the dexamethasone in the more sicker patient, but not on the patient that doesn't require oxygen supplementation. And this is the dose for the dexamethasone, and then this is the use of steroid for the MIS-C. And then now for the immune modulator treatment, there are a couple of them. And then here's the indications, like based on the clinical sign, laboratory finding, and also some deterioration of some organ functions that actually dictate us to use the immune modulator. And then there's the anakira is the LI1 inhibitor, and then the IL-6 inhibitor is a tocilizumab, and this is the antibody cocktail that we heard very frequent recently. There's a combinations of casirivimab and imdevimab, which is like produced by Regeneron. And then we talk about immunoglobulin, and then I think everybody knows about the IVIG, and then this is how it works. And then I will skip through this a little on the faster side, and then this dosing that we have, and then there's also convalescent plasma, and then there's a human plasma that contains anti-SARS-CoV-2 antibody, so that has been used, and then there was some potential risk associated with that, and then there's all listed here. And then we can also do plasma exchange, and then you can exchange with food, and then we also talk about the mesenchymal stem cell. This is still on the very early phase, and it's still on the clinical trial period. And then by the understanding of the mesenchymal stem cell, it should work, but then clinically it still needs a lot of work. And then, of course, the chloroquine, hydroxychloroquine, and then, of course, everybody heard about in June, mid-June, WHO stopped the hydroxychloroquine treatment arms from the Solidarity trial, as there's no, they don't find any efficacy compared to the standard care patients. But then this actually doesn't include the use of hydroxychloroquine and pre and post exposure prophylaxis of patients with COVID-19. And then we heard about azithromycin, and then the famotidine, the Pepcid, the ACE2 blocker, and then the zinc, and that has several antiviral effects. And then vitamin C, and then is best known for its antioxidant properties. And then this topic came out is partly due to the CITRIS ALI randomized control study. And then so at Stanford, we do have a COVID-19 management algorithm, and then as shown here. And then there's also some other institution have the MIS-C treatment algorithm. And then there's also, this one is from Mount Sinai, New York City. And then COVID-19 with ECMO, and then so of course, like when everything else fails, and then one thing that we can try is actually try to put the patient on bypass, either VV, venous venous, or veno-arterial. And then, but it's very important that for this is very label consumptive. And then so for the places that never done this before, this is probably not a good time to actually try it. And then actually on the center that actually runs the ECMO, so there's like 4 different tiers of capacity based on the patient load, and then the limited resources for personnel that run the ECMO. You know, from the conventional capacity that we can do it, and then at the crisis capacity. So there was a different selections of patients, and this map shows like what's available for ECMO in the world, and then the right side is show what's available around Indonesia area. So, of course, like this talk wouldn't be complete without we don't bring out the issue on vaccines. So shown here are different type of vaccines and what is actually the leading candidates to get into clinical usage now. And then the pediatric BLS, the American Heart Associations, together with the American Academy of Pediatrics, come up with the interim guidelines that adjusted for patients with COVID-19 or suspected COVID-19. And then basically, they focus on the aerosolized generating procedures, you know, like the CPR, endotracheal intubation, non-invasive ventilation that may expose provider to greater risk of the disease transmission. And then and also stress on to perform this in the isolation room. And then everyone should don respiratory protections. And they have this is for the single rescue, for the 2 rescuer. And then you know, also very important that ventilator with oxygen using the back mask with the filter and tight seal. And if not available, then you can use the non-breathing mask. And then these are the important adjustments that are also shown here is like, you know, the PPE, and then it's all the highlighted red area. You know, everything is focused about limiting the personnel that providing the care from getting contracted with the virus. And that include the neonatal resuscitations. And then actually I have a video here, but in the interest of time, I don't think we'll run it later on. We have some extra times. Simulation, you will see. And then so finally, I would like to thank you for your time. And then stop here. You know, it's a big topic to cover. And then yes, we all changed our routine. This is our routine now in the ICU. I apologize for the pictures here. This was taken during our Halloween time, and all my nurses actually try to dressed like me, so I'm being cloned. And then, so again, thank you so much, everyone, for.
Thank you very much, Mr. Rosley, for the wonderful presentation about COVID-19. Ladies and gentlemen, please hold your questions for the honorable speakers for the discussion session. Now please welcome our second speaker for the session, Mr. Tito G. Vivas Putrago. But before that, let me read his summary of the CV. Mr. Tito Vivas Putrago was born 32 years ago in Bogota, Colombia. He is now a postdoctoral research fellow in neurosurgery and neuro-oncology, Department of Neurosurgery, Mayo Clinic. And then his education, accreditations, and memberships are, before that, I'm so sorry if I mispronounce so many words. In 2020, he is the associate member of the Congress of Neurological Surgeons, or CNS. In 2017 until present, he is postdoctoral fellowship in neurosurgical oncology, Mayo Clinic, Department of Neurosurgery. In 2016-2017, postdoctoral fellowship in hydrocephalus and CSF disorders at Johns Hopkins Hospital. And 2015-2016, postdoctoral fellowship in neurosurgical oncology the Johns Hopkins Hospital. 2014, research elective in neurosurgery, Laboratory of Neural Stem Cells, the Johns Hopkins University, Baltimore, USA. 2008-2014, University of Santander, UDS, School of Medicine, MD, at Columbia. 2007 to 2008, International Stay for EF English Study. And 2006-2007, Bachelor Academico in Columbia. He also got some honors and awards, just like Salisbury Family Foundation in 2016. A year before, he got Nurtama Center IBS for honors and awards. In 2008-2014, he received this for every year, the full-ride scholarship from medical school at Universitas de Santander, UDS. And 2007, he got honors and awards from Major Y. Hogger Foundation, England, UK. He is also granted patent applications, and he also is very active in writing some publications, also a reviewer of some journals. He has so many experiences about teaching. Yeah, there are so many experiences and awards for Mr. Tito Vivas Puitrago. Okay, good evening, Mr. Tito Vivas Puitrago. How are you today?
Very good. Good morning.
Yeah. Is it evening there, Mr. Tito? Sorry, I think you are still unmuted.
Now?
Sorry?
I think the host is muting it when I'm muting it. So let me control it from here. Can you hear me now?
Oh yeah, you have 30 minutes to present. Time is yours, Mr. Tito.
Perfect.
Yes.
So let me see if I'm pronouncing this correctly. Good morning, Sulamat Pagi. And that's how about
are some of our floors and ORs. This is an actual spine case that you can see. Some of our consultants and chief residents. This is the city, Jacksonville, Florida. It's up north in Florida, but believe me, it's very cold right now. We are at 4 grade centigrade right now. So I would like to thank you again for the invitation, especially Dr. Michael Lumington, who is a doctor at your institution. He's a neurosurgeon. He just received his degree last year, if I believe so. He became a very good friend of mine and a colleague during his time here at the Mayo Clinic, and he actually gave me this batik. Am I pronouncing it correct, batik? I know he told me it's a very traditional clothes shirt that is wearing for special occasions in Indonesia, and I was actually saying, this is the first time I wear it. So I was actually planning to wear it during his wedding, but I say, okay, I don't think he's getting married anytime soon. He's very focused in his professional career right now. So I think this will be the best occasion for me to wear the shirt. So thank you very much again for the invitation. And you heard already all the clinical care that is from Dr. Harrison. So I would like to talk in this occasion about what is the impact of COVID-19 and this pandemic in our neurosurgical practice, training and education practices here at the Mayo Clinic at the Jacksonville campus. This is some of our department members. This is Dr. Alfredo Quiñones, who is the chair of the department, Dr. Aboriyama, who is a spine surgeon associated. He's an assistant professor here at the Mayo Clinic, Florida. Gaetano Villasi, a colleague of mine that has been working very diligently in this topic of COVID-19, especially how has it impacted our practice here at the campus, and Tito Vivas Buitrago. So I have more relevant disclosures for this presentation, and I would like to start by showing to you this publication that was already submitted and accepted at the Mayo Clinic Proceedings, which is a very good journal with high impact here in America, talking about what is the path that we took to reopening the surgery service in this pandemic. We call it the neurosurgery experience. More relevant disclosures. So let me start by showing you here. This was, like, as we call it, the first peak of COVID-19 cases that we presented at the beginning of this year. And this is a graphic that you can see from March 26, 2020 to April 27 to 2020. This was the first week. How is the time frame in which the mandatory quarantine was ordered statewide, and we wanted to look at this period of time to see how our department and the Mayo Clinic in Jacksonville in general took some precautions to continue with the practice and continue with the providing care for its patients, as well to continue to provide education and research developments. So the most important item of our protocol was to reduce or minimize the exposure to COVID-19 in both our staff and our patients. So for that, we implemented travel restrictions for our staff. We also implemented some social distancing policies by limiting the personal meetings to up to 10 people and promoting virtual platforms. Also that required closely daily temperature checks, and we also had to sign and fill an online formulary before entering to the hospital every single day. We also dedicated a specific phone line for the staff to call the suspected that have developed COVID-19 symptoms and to receive more further indications and recommendations. And we require to all employees to wear a mask on the campus and provide them with a surgical or cloth mask to all of them free of charge. For the patients, of course, we had to limit the number of visits to the inpatients and the emergency room patients. We also have to check the temperature for all patients before entering the hospital every time, require patients to wear a mask while on campus, postpone all the elective surgeries and test all the surgical patients within 48 hours before undergoing a non-elective procedure. So during this first wave from March to April, we wanted to evaluate the response that our neurosurgical department has during this period. So we developed this perioperative COVID protocol to first recognize and establish if the patient really needed a surgical procedure with urgency. So let me guide you to this protocol. So if the patient is the patient in need of surgery, if the patient is admitted to the hospital, we run an inpatient test. If the patient is outside of the hospital, we direct the patient to get a test in a drive-through that Mayo Clinic facilitated in the parking lot, so the patients can just get in the car, drive to our parking lot, go through the drive-through testing, get their test and wait for their results. Okay. If the patient was positive for the test, now we need to evaluate if the surgery is urgently needed. Okay. If yes, the patient needs to, of course, proceed with the surgery, and we need to put the patient in a dedicated OR, only habilitated for patients that tested positive for SARS-CoV-19, and also they require a special intubation protocol outside of the OR because, during the procedure of the intubation in a confined space at the OR, we maximize the exposure of the virus to the rest of the staff. So if the patient tests negative, then we can move the patient to get a surgery in a regular OR with a regular protocol of intubation. So then, what about if the patient tests positive, but we determine that surgery is emergent, but it's not urgent, okay? So we prefer to minimize the exposure, and of course, for the safety of that patient, we place the patient under quarantine for 14 days and we retest in the middle and at the end of this quarantine. So if the patient tests negative, we proceed with a regular protocol, placing the patient in a regular OR with a regular intubation protocol. If the patient still tests positive, we continue to repeat more tests, and the patient, of course, is going to be maintained under quarantine. Nonetheless, if the patient keeps testing positive, and now we see that the surgery is urgent, now we have to move the patient to undergo this procedure in a dedicated OR under the special intubation protocol. So, in this month alone, from March to April, we had 103 non-elective cases. We established that the patients needed to undergo surgery urgently. So we saw that we have roughly about 59% of spine cases, 98% of these cases were cranial, functional were about 8%, and vascular cases were about only 5%. So this is to show you that even in the midst of this pandemic or any other crisis, we also have to come work as a team, develop new protocols, and provide the care to the patient. That's the most important aspect in which Mayo Clinic is focusing. We cannot just take the recommendations from the government authorities and just say postpone all the non-elective cases We also develop new methodologies, as they have been developed worldwide, seeing the patients in teleconsult through Epic and through Zoom, because the patients, they need to keep hearing from their healthcare providers. They need to be guided during this process. This is uncharted territory for us and for patients, but we need to make them see that everything is under control, that we are going to take care of them and we are going to be worried for them. Okay? So that was one publication about the experience of the neurosurgery department of the Mayo Clinic Campus, Florida, during the month of March 31st. This is another publication that was also accepted, and is the telemedicine utilization of neurosurgery during COVID-19 pandemic, a glimpse into the future. So remember that every challenge is also an opportunity, okay? And sometimes rough situations, as pandemics, as has happened before in our history, also force us to move outside of our comfort zone and just imagine the future. And it forces us also to implement those new innovations in our present, okay? So, of course, this pandemic has been terrible, but it has also given us the opportunity to advance our field, advance our care, advance with the help of technology in many ways to provide the care that our patients need. So, of course, we have to protocolize, and we have to see and differentiate every single case. We need to see the patient needs acute care, or if the patient his affliction can be resolved to an ambulatory care. And of course, we need to continue with all these follow-up in the post-acute acute care, and all of this is being doable thanks to many technological tools that the Mayo Clinic has embraced and implemented. So here at the left side of the screen, you can see that at the end, at the month of March, 94% of all the face-to-face patient visits that we were having here were like, the majority of them were face-to-face, and only 2% and 4% respectively were phone visits and video visits. Now, in the time frame, only 1 month later, we were able to change that by implementing all these telemedicine protocols, and we now can see that for the face-to-face practice was reduced in 45%. And those 45% that were seen face-to-face, that means that with the patient inside of the hospital were mostly urgent cases that needed surgery. As you can see, the phone visits and video visits, they had a very significant incremental amount in numbers, and of course it was statistically significant, as you can see here. So this is the demographics, is to show you that age is not a barrier for technology. Many of, and either the location. So as you can see, we have patients from all over the world, from America, from Europe, from Asia, from Latin America, etc. So it actually gave another opportunity for international patients to get access to international care, to first world care. So we can see that the age is not a barrier here, because the median age of our patients that receive a clinical consultation via telemedicine was 62. And here we can see the overall assessment of our practice. It was done by the patient satisfaction. Okay, so we did a survey to every single patient that received a video visit for their care, and as you can see that there were no difference between those patients that received a visit inside of the hospital with a face-to-face consultation in comparison with those who received a teleconsultation. So they were very happy at the end, and the most important part is that they actually were very grateful at the end because they didn't feel the barrier actually being the other side of the screen. Because the most important part of the physician and patient interaction is to be honest and try to work things around, especially during these challenging times. So with that, I would like to conclude this presentation that was basically on the experience of the Mayo Clinic Department of Neurosurgery at the Florida campus. And I'm open now for any questions.
Okay, thank you very much, Mr. Tito, for your wonderful presentation. Yeah, ladies and gentlemen, please hold your questions for the honorable speakers for the discussion session. And all presenters already did their presentation. Now is the discussion session for 30 minutes. Ladies and gentlemen, we invite you to give your questions or comments for the two presenters. You can give response using your microphone or your chat window. But before delivering your response, please mention your name and also your affiliation, and don't forget to whom do you want to give response. Okay, ladies and gentlemen, you have 30 minutes for Q&A session. Okay, or maybe you can raise hands so that the committee can unmute your audio.
Okay,
or
thank
you can write something, your questions, your comments at your chat window. Silakan bertanya, Bapak Ibu bisa langsung bertanya secara live atau bisa dengan lewat chat window ya. Anda bisa menuliskan pertanyaan di kolom chat. Silakan. Our conference is also can be watched live on YouTube. Some people already asked at YouTube, but before that, we can go to this one first. Yeah. Please raise your hand if you want to ask some questions so that the committee can unmute your microphone. Sorry for that because you cannot unmute your microphone yourself.
Yeah. Can I ask questions?
Yes, please.
Yeah. Okay. I'm Julia Kartika coming from Untak, Surabaya, and I want to ask to the first speaker. Yeah, to this first speaker that I really want to know what happened with the children who has the COVID, critical COVID, and then what is the impact after they have already cured? And the second, is it okay to have them a donation or donate to the people who get sick with the plasma, comparing to the one to the adult? Thank you.
Okay, is that Ibu Yuliar?
Yes. Yes, I think I actually I would try to answer this, and then I got the questions very clear. And thank you so much, Ibu Kartika, and then from Sultar. I think basically Ibu Kartika has 3 questions, and then I am trying to answer that. And then one is what happened to the critical care ill children that has COVID-19, And then well, it depends on the severity of the illness. And then so at the beginning of the phase, we saw like a practice a lot more like a community medicine. Like at the time, I think because it is a very uncharted territory, and then so we don't know. Actually, it's like we don't want to actually get our people sick, and so we try to protect all the caregiver. So then at a very early phase, then that a lot of like for this critical ill patient, there's a lot of like early intubations and early putting a patients on mechanical ventilator support. And then so at that time, I remember very well in March, I think it's like, we actually like try to train everybody, do a lot of simulations, and then we try to not even using high flow, but apparently it's very difficult in children because many times, as we all know, we treated children in ICU, they do really well with high flow, and then they do pretty good with non-invasive ventilator, but those initially was taken off the list. So we do a lot of early intubation, but that actually doesn't do well. And then now, I think since we are able to control better, and then again, luckily, and then children are not typically very sick. So then our ICU, and then it's pretty much like we have capacity, and on top of that, we hold back a lot of we hold back a lot of elective surgery. So then, we do have a lot of capacity. So then we went back to the practice that we usually do. Okay, we support, we try to scale back from doing community medicine, become doing individual medicine. So basically, we only give whatever the patient needs. So if the patients need support in terms of respiratory of high flow, they get high flow. They need a non-invasive, they get non-invasive. And then at the time when they need to be intubated, they get intubated. And then to this date, I think out of these critical care ill children in the state of California, we only have 2 deaths. And then again, we don't have that many critically ill children. So I just speak from the experience that I have working in this side of the world, and then with especially in northern part of California. And then so now questions number 2, and then what is the long-term impact of COVID-19 disease in children? And again, this is a new territory, uncharted, and then so of course the follow-up is ongoing, and then so it's very difficult to actually nail. I mean, we're not even a year into this, and then from the experience that we have from RS respiratory failure, and then you can see that RSV stands for respiratory syncytial viruses, and then from the influenza viruses, we can see that there's some study have shown that, and some long-term study has shown that can increase the incidence of asthma, and then but we don't know. I'm not saying that it's going to happen to COVID-19, and then so we don't know, but. But the good part about children is they tend to regenerate, and then so the lung regenerate pretty good, and then so as they are younger, they actually do better. And then I think typically when they're younger than less than 8 years old, and then they still budding pretty well, and then so the lungs totally recover pretty good. And then so we don't know. I think this is something that we need to keep following and see where is that leading to. So that's question number 2. And then question number 3 is about convalescent plasma and then children as a donor. And then this is very tricky. Typically, you need volume. It's like so volume is that determines how much you can take out from patients. Now, typical body volume is when you want to take out the plasma from the donor, so you need to fill up the whole donor bag. And the donor bag ranges from about 250 to 500 ml. And then so now, total body volume in children is about 80 per kilo. And then, so you're talking about 10 kilos. So you take about 250. You take a lot of them out from the children. So at this point, they're not donor unless they are closer to the adult size. That's a different story. So typically, you're not getting children as a donor. That's number 1. Number 2 is again, they have the illness, they have milder illness, and then they tend to be outpatients too. And then typically it's very difficult to actually get a consent from a parent to actually get the children to donate their blood. You know, so that's a very typical practice. Even though they're on the adult side, you know, we need a consent, until they're 18 years old. Now, anybody's like, we still treat patients up until they're 21. On certain circumstances, like, you know, like a chronic neurology patients and then congenital cardiac patients, we go beyond 21 years old. And then, but again, we don't take them as a donor for all those chronic patients. They're not donoring anything. And then, so I think on the children part, typically the answer is we don't use their blood, even though we record them, you know, and then take them as a donor. So that's probably the answer. And then, so I hope that can answer all Ibu Kartika questions. And then I'm willing to discuss more. Thank you.
Okay, thank you very much, Mr. Rosli. We have some other questions after from Ibu Kartika. The second question is from Dr. Nir. He is from Universitas Muhamadiyah Gresik. I'm going to read his question from the chat room. So, my question addressed to first presenter. First of all, I need to inform you that actually my area of discipline is not health science, but there is one thing that questioning myself after listening to your presentation concerning with COVID-19 related to children death caused by COVID-19. According to data that I have taken from Department of Health, I hope I'm wrong in quoting this data. It mentioned that in Indonesia, approximately 54% children death in all deaths caused by COVID-19 in age of range from 0 until 4 years old. And according to the chairman of Ikatan Dokter Anak Indonesia, that children death caused by COVID-19 in Indonesia is the highest in Asia. And his question is, as the expert in this discipline, what is your comments on this phenomena? Do you think that there are more to be done by Indonesian government? By Indonesian government. Do you think that something missing regards to the COVID-19 prevention and handling efforts in Indonesia to decrease the figure of children death caused by COVID-19? Okay, Mr. Rosli, do you want to answer the question directly, as there are some questions from Dr. Nir?
Yes, thank you so much. Thank you for the questions, very interesting and good questions, and then I hope I do have an answer, but again, I have to mention here again and again, and every time I give this thought, it's like, COVID-19 and then it's an uncharted territory. So, you know, we are learning as we move forward. And then, so yes, I know we know more now than about 6 months ago. Okay, so let's start with, I think it was mentioned that the Indonesian data, 54% dead, and I'm trying to get this right, the statistic, and then is that 54% of children with COVID-19 disease ended up dying. And then for the age group of 0 to 4 years old, or 54% death of children of 0 to 4 year old from all comers that actually has the COVID-19. I'll try to clarify these questions. Yes, it is a very high number. I'm sorry. Yes. Hello. Hello.
Yes.
Yeah.
We hear you.
So okay, you know what? Try to answer that, and then from what my experience is like in the part of the world that I am in now practicing. So children are typically they are asymptomatic, and the majority, if they have anything, they have a very mild illness, and then so that's what we see. And then so now to this date, in California state, we only have 2 deaths. And then yes, we do have about 23% of our children with COVID-19 positive. Now, I think I apologize that I might have gone a little too far about the couple of potential protective factors for children, like, so they actually fare better compared to adults. And then, from the, the anatomy of the airway, it's like, they typically, when they're younger, their funnel shapes. And then, so then they tend to actually turbulence, as they are going to the narrow part, and then the air is very hard to get in. And then, so then, at that time, you limit the viral load. And then again, there's the illness severity is very dependent on viral load. Now, so why is that in Indonesia is higher? So, because one of the reasons I think is like, I mentioned, and then we thought that may potentially explain why it's less severe in children is like, because there's a lot of innate response, and then they're actually stimulated from children getting their booster immunization. And then of course, like, they will complete that, the basic booster immunizations like completed when they reach up to 5 years old. And then, so then, when you compare those group, and then yes, this 0 to 4 is at the lower age group. Now, I don't know what's the rate of immunizations. Like, I'm not saying about COVID-19 immunizations or vaccination. I'm talking about overall rate of immunizations in the country, in Indonesia. I don't know what the rate is at now. Now, is there any difference between the rate there and the rate in US? And then, so that could be potentials like, explanations why, they don't build up that much innate immunity against the disease. And then the other thing also, and then, 0 to 4 years old, that actually, that's actually where you group also the prematurity. I don't know what the rate of the prematurity, and because we know one of the risk factors for getting a severe disease is prematurity, and then those are less than 1 year old. So now, could that be a lot of like a prematurity actually included in there? Now, I think the percentage could be high because, in a way that typically prematurity children get documented better because they receive hospital care, and then a lot of like other children doesn't. So then, could it be potentially like, the way that there's a little bit sampling, a little bit better on this particular age group that actually contributing to the higher number of that, because they tend to get sicker, and of course those with comorbidities like congenital heart issues, and then metabolic problem, inborn error metabolism, and then those are all being followed a little closer so that they have a better data recorded. Could that be a possibility? I don't know. I'm just throwing out a lot of potential explanations that I think we need to look into this. And then so I hope these actually I'm able to try to at least, if not partially, answer to your questions, Dr. Mir.
Yeah, thank you very much, Ms. Rosie. Now since there are questions from the participants, the third question is from, I'm sorry for this, Bapak or Ibu Yudhithia Maxi Sally. I'm going to read the questions. Yeah, thank you for the explanation. My name is Yudhithia from University of Pajajaran. I have a question for Mr. Rusli, the first speaker. You said that chloroquine is not recommended for kids. How about the adult? Actually, can you explain more about the effect of the substance? Because in Indonesia, still have research to develop Sinuca as the natural hydrochloroquine as the medicine of COVID. Thank you. Mr. Rusli, will you please unmute?
I'm able to unmute myself now. I think the questions, like, let me repeat that, is about, of course, we're talking about, when we talk about chloroquine, I think it's like, we sort of like talking about more on the hydroxychloroquine, on the much benign side of the chloroquine, the derivative. And then, so now, I don't actually, it's like the one slide that I put in, that I mentioned about chloroquine and the hydroxychloroquine is actually, that actually refer to adult. And then, then I am in practice, in my knowledge and everything, so I'm actually a pediatrician. And then, but I'm trying to actually answer based on what I read and what I know. And then, what happened is, like, there was, like, I'm trying to pull out a slide. I'm trying to look into, the mechanism of actions. I think it's like of chloroquine or hydroxychloroquine. I think, if I am not wrong, it's actually the two-way of proposed potential work of chloroquine or hydroxychloroquine. I think one way is actually to prevent the virus from entering the host cell, and then the other one is actually as also they can actually boost up anti-inflammatory responses. And then so you can actually go both ways. You target the virus, and then you can target the host over immune response from the host. Now, the data, in adult populations, I think it's like, it become a concern. Again, this is uncharted territory, so it's a lot about risk and benefit. And then, so now, of course, in the risk of hydroxychloroquine, and then more so of chloroquine is actually, they mentioned about the arrhythmia, and then so now we know that in older populations, like they tend to have some issue with the cardiac related issue, and then so that's something that actually is like, we have to see that exposing adult patients to chloroquine and hydroxychloroquine is more beneficial to them, or may potentially creating more harm. Now, the WHO in June 17, 2020, about 5 months ago, actually halted the hydroxychloroquine arm. I think that the solidarity trial is actually to look for any effective treatment. I think inside that there was remdesivir, there's the combinations of the lopinavir, and then and also there's the other one is, I think the combination is lopinavir, ritonavir plus the I believe it's TNF. So they try to look into that, but then then the control is actually just doing the standard care. And then but they realized that at that time that the hydroxychloroquine group is actually fared no better, to the control group. So that's why it was stopped. And then I do not follow the study. I believe you mentioned is the Sinotech study in Indonesia. I do not follow that. But having said that, the actions from that actually doesn't apply to looking into hydroxychloroquine as potential pre-exposure prophylaxis or post-exposure prophylaxis. So I think there are studies still ongoing on that part. So I'm not sure if the study in Indonesia is actually in the context of that, rather than in the context of finding the effective treatment. So that's, I think, like, what I do have to hopefully, can help you a little bit with your questions about chloroquine or hydroxychloroquine. Thank you.
Yeah, thank you, Mr. Rusli. And the next questions will be for the two presenters and also for Mr. Tito. There is a question from Professor Alfi. His question is, how long can this virus survive in the outside environment? This is for the two speakers. I invite Mr. Tito to speak first and then Mr. Rusli. Thank you.
So, to be honest with you, that's outside of my area of expertise. Since I'm more in the surgical and the neurosurgical area, so I will defer the question and the answer. I think it's more appropriate if Dr. Harson or illustrate us about this. But I've seen many publications that they say that depending on the material in which the virus is located, the time of survival varies. It depends if it's in the environment, the end, in wood surfaces or in metal surfaces. I'll defer the question to Dr. Harson.
Okay, thank you very much. Mr. Rusli, please. For how long can this virus survive in the outside environment?
Yes, I'm actually, I was trying to look for the table that I believe, okay, let me first of all, say that, well, thank you, Professor Arvi, for these questions. And again, I think, again, I am not the virology expert at all, but I believe, like I read, I was trying to look for the table of the table with Dr. Kunonis was talking about, and of course, like every time I'm trying to look for that, and you just couldn't find it. And then so I think that's actually you're referring about the formite method of transmission. When the viral particles and then for one reason drop into certain surfaces, and then how long it still lasts and then stay on that surfaces, so you can infect a person that is in contact with that a particular object. And then I think that I believe there are a study that's very early in the phase of the pandemic that actually shows how long those virus actually survive. I think it's difference between different object, metal, plastic, and all this stuff. But again, I can't find out the I try to get that table to give you a really concrete answer, but I just cannot find that. I think it ranges from hours to days. So those are under what we call the formite transmission mode. And then I'll try to find it, and then maybe I can actually, if I can get the contact information, I can actually send it to you. And then I think then you can have the accurate information about this. And again, I am not the expert about this virology, and then I am more of a clinical person. Bob, thank you.
Yeah, thank you so much for the two speakers. And the next question is from Dr. Ernawati. She is from Universitas Muhamadiyah, Gresik. Her question is to Mr. Tito. When does the COVID-19 end, based on international journal reference? Mr. Tito?
Thank you very much for the question. I wish I had a vision of the future, a time machine to tell you exactly when it's gonna end. But once again, this is uncharted territory, so there's no clear answer, and it's either that one option is everyone gets infected and acquires immunity to it, or we get vaccinated for this. But the best option right now is just to stay away from crowd areas, stay at your home, try to do all your work by teleconferences, and just be patient. We have gone through a lot, but I truly believe we are at the end of this very terrible path.
Okay, thank you very much. And there are still some questions, but maybe because of the time, I just take the questions for the two presenters. We have a question from Universitas Merdeka at the chat window. Yeah, this is from Universitas Muhamadiyah. I want the opinion of two speakers whether COVID-19 is merely a matter of science or is there a role for God to remind destructive behavior of smart people? So what should mankind do besides science to deal with this pandemic? Okay, I invite the two speakers to answer the question from Universitas Muhamadiyah. Mr. Tito, do you want to speak first?
So, I think pretty much all of us were pretty religious, and of course we see that there is the influence of God on everything. So we pray, please God, help eliminate all these scientists, so like that we can try to get these vaccinations, these vaccines as soon as possible. All right. So right now there are at least 2 or 3 big pharmaceutical companies that are already in the final phases of approval of their vaccines. So I think that the hard work has paid, and it's just a matter of patience and just wait a little bit longer so that we can get all the approval phases finished, so like that we can start working on the distribution.
Okay, I think this is a very interesting questions, and then from Mr. Umar from, I believe it's from University Merdeka, Madiun. I think at this stage, I think it's like, what we're facing with a pandemic, and then I'm also a person of faith as well. And then, so I'm just saying that I think the most important thing is like, I think there's an Indonesian saying is like, manusia bisa berusaha tapi Tuhanlah yang menentukan. So I think that's a very good saying about that. And then so I think regardless what the challenge is coming to the earth, the world, and then we can look at it at a different perspective. I think it's like, what we need to do is like, yes, we need to do our part. Everybody has to do their part. And at that time, the best part that each individual can contribute to this is actually by limiting the spreading of the virus. And then, that will be by masking, and then by social distancing, and doing all the part on your own. And then now, so by doing that, actually, it's like you are contributing to the cause, the good cause to the society. And then, yes, eventually, I think it's like, God would actually decided, what's the end of this. And then, but if you're seeing from the God's angle, which I'm not really able to see it, but I would think that, well, you can see in a very positive way, is that maybe there's a reminder to everybody to actually, do the good part on the end. Everybody, has to partake into this. Everybody has their role. And the role is like to prevent the spread of the illness for the greater well-being of everybody. That's my 2 cents. Thank you.
Yeah. Thank you so much for the 2 presenters. And I'm so sorry because of the time. It's already 30 minutes for discussion and sessions, even though there are still some questions that is unread because of the time. Yeah. Mohon maaf sekali lagi untuk Bapak Ibu yang sudah bertanya, namun karena waktunya yang tidak memungkinkan, kita berusaha untuk menempati waktu 30 menit. So thank you very much for your participation, for all the participants. And so ladies and gentlemen, the first plenary session is over already. To honor the 2 speakers, we would like to give the e-certificates for the presenters. The first e-certificate goes to Mr. Rusli Harisono, MD, MBA, MSc, FAEP from Stanford University, California, USA. You're welcome. And the second certificate goes to Mr. Tito G. Vivas Puitrago MD, PhD from Mayo Clinic, Florida, USA. Oh, MD, PhD.
In the future.
Oh.
I'll need to think about it.
Okay, yeah. I'm so sorry for that, Mr. Tito. Yeah, thank you very much for the wonderful presentations of the two presenters. And we invite Dr. Hoirul Anwar as the Vice Rector 1 of Academic Affairs of Universitas Muhamadiyah Gresik to give the farewell speech to the keynote speakers. Dr. Hoirul Anwar, time is yours.
Well, thank you very much, Bu Rohmi Husnia. I think on behalf of University of Muhammadiyyah Gresik, first of all, I would like to express our gratitude to Mr. Tito and also Pak Rusli, Bapak Rusli, for the time and also the opportunity of giving materials. And I think the presentation is very, very good and very useful, at least for all participants of UM Gresik 2020, and the themes of the materials quite updated, and I think based on the experiences and the knowledge, practical experiences are very useful for the participants. So finally, thank you again, thank you very much for the contribution. Hopefully we can contribute to other more seminar with current issues later, perhaps for the next year. Thank you very much, by the way, Pak Tito and Pak Rusli. Thank you very much.
Yeah, thank you very much. And for the honorable two keynote speakers, if you need to, you may log out of Zoom. Thank you very much for your presentations. Terima kasih banyak Pak Rusli juga Bapak Tito. Again, ladies and gentlemen, now let's move to the second plenary session. The two speakers of the second plenary session are Dr. Hasimah Jafar from University Pendidikan Sultan Idris or UPSI, Malaysia, and Regiwati Pusporini, PhD from Universitas Muhammadiyyah Gresik, Indonesia. Is going to start the presentation after I read the summary of her curriculum vitae. Dr. Hasimah Jafar is the head of English Language and Literature Department, Faculty of Languages and Communication. Dr. Hasimah Jafar is the head of English Language and Literature Department, Faculty of Languages and Communication, University Pendidikan Sultan Idris, UPSI, Malaysia. For academic qualification, she got her EDD, Doctor in Education, from Nova Southeastern University, USA, MED TS from University Pendidikan Sultan Idris, Malaysia, PED for TESL as well from Nottingham University, the UK, and Teacher Training Certificate from Kota Baru Teacher Training College, Malaysia. She also got some awards. The first one is Excellent Service Award, University Pendidikan Sultan Idris in 2019. Second one is Certificate of Excellent Service from University Pendidikan Sultan Idris in the same year. And then the third one is from UNESCO, APCIU for Best Practices UNESCO 2010. And then Excellent Service Award from University Pendidikan Sultan Idris in 2005. And the last one is Excellent Service Award from Ministry of Education, Malaysia in 2001. Her research interests are in teaching and learning in structure, reading fluency, remedial reading, adult literacy, and English language literacy. Ladies and gentlemen, Dr. Hasimah Jafar is also writing some publications, the reviewer of a journal, and active in presenting seminars and workshops. Okay, let me greet this wonderful presenter, Dr. Hasima Jafar. Good morning.
Hello, I am Associate Professor.
Yeah, how are you today, Doctor?
Yeah. Everybody okay?
Yeah. Okay, Doctor, you have 30 minutes to present yours. The time is yours, Dr. Hasima.
Hello, I am Associate Professor Dr. Mazura Mastura Muhammad, the Dean of Faculty of Languages and Communication, University Pendidikan Sultan Idris, Malaysia. I would like to welcome everyone, invited speakers and delegates to Umgeshic 2020 online. Ladies and gentlemen, this is our university, and I would like to ask you to enjoy our video about our university. Thank you.
Okay, Dr. Hasima, I'm so sorry for the technical problem. Would you please start your presentation in 30 minutes?
Okay. Right. Right. I'm ready, yeah? Okay. So, that's me, and today I will be speaking on online learning, voices of the students. Now, to me, this is very important, yeah? Okay, next slide, please. Next slide, please. Next slide, please. Okay, that is my university. We have two campuses, yeah? The one, number 1 and number 2 are the old campus. My faculty is situated on this old campus, and number 3, you can see that is the new campus, the one that was shown in the video. Okay, now and we want to be number 1 in the teaching, in the pedagogy, in the pedagogical aspect. Okay, next please. Okay, we have two doctors talking about COVID-19 just now. I'm not a medical doctor. I'm just an academician like most of us. Now, the coronavirus disease is a global pandemic. We know that. And we are so afraid of the virus, and we find ways, how to stop it from spreading. And from advices from the doctors, we found that we can stop the spreading of the virus through physical distancing. If we wear surgical masks, we wear masks, we keep our rooms well ventilated so that the air can come in and out. We avoid crowded areas. We always clean our hands with soap and water, or we can use the sanitizer. And then when we cough, we will bend our elbow and we will cough on our elbow, or we can use tissue paper. Okay, that is how we stop it. Okay, next, please. Okay, so now, from what we heard, from what we know, social distancing appears to be the most effective way. That means if we do not, we cannot stay indoors all the time, we cannot stop working, we cannot stop everything. So we have to find ways how to stop it, and we found out that social distancing is very effective. And because of this pandemic, a lot of countries have introduced the movement control order. Like in Malaysia, people will be arrested if they do not abide by this order. And then even in China, in Wuhan city where it was first discovered, there was a total lockdown. Businesses were closed, school were closed, everything was closed. Okay? And then we found out that because of this pandemic, we can see that lectures and tutorials have to be shifted online. We cannot have face-to-face classes because we don't want to spread the disease. So the Movement Control Order, or the MCO for short, imposed in Malaysia has impacted the tertiary education in Malaysia. Okay, we can see that it has really impacted, and we got to change our style of teaching. We have to change our classes, we have to change our tutorials, and there's a change, a great change. Next. Okay, so according to Sun and Chen 2016, they say that there are many debates on, the differences between online learning and face-to-face teaching. Okay, now there can be debates, but my concern is what are the students' thoughts about online learning? Because school introduced online learning, tertiary education introduced online learning. It is what we do, but what about the students? What are their thoughts? And in order for us to be very successful in our teaching and learning, we must listen to the students' voices. So that is what I'm going to look into in this presentation. Next. I have 3 questions here. Okay, I ask my students, what do you like about online learning? We have to be fair, because some of them do like online learning and some don't like, so we want to know what would you like about online learning, and we also want to know the differences. How does online learning match with your experience in the actual classroom? Is it the same? Is it different? That is what we want to know. Okay, next. Next please. So you see, first we have to understand what online learning is. So online learning is not something new, because a lot of university, even when I did my doctoral study, I was doing blended learning, that is distant education, because I'm in Malaysia and my university is in Florida, is in Florida, so Fort Lauderdale to be exact. So I went to America for twice, for 6 months, but the rest of the study I did it online. So it is also referred to as e-learning, okay? And now we call it remote teaching and learning. Remote because we are far away from each other, So it is different from the traditional learning because you see, you have this, according to Min Hu and Ho Lin, and also to Stern, okay, they say that this online learning is something that you will do with internet access, okay? And then because it is internet based, it can be done synchronously, meaning it is live, or you can have it recorded, okay? You can have it recorded, and then that will fall under asynchronous learning, right? So it can be carried out synchronously or asynchronously. Okay, next. Okay, so here we can see that this online learning, because of the use of internet, the use of the network, we can see that there is a pedagogical shift of how teachers teach, how lecturers teach, and how students learn. Okay, so there are people who said that no, online learning is good because it is top-down lecturing, where traditional classroom you have only passive students, where the lecturers are in charge, okay? And here with online learning, it is said that there will be very interactive, and then there will be a collaboration between the students and the instructor, and where they co-create their learning process, where they discuss what they want to do. Okay, next. Okay, so why do we need to study online learning? Number one is very simple, because we are using it. Okay, it is here to stay, and it has become the mainstream of learning. Everywhere we go, I don't know about Indonesia, but in Malaysia, the primary school, the secondary school, the tertiary education, we all have turned to online learning. So that's why we have to know what it is. Okay? And then, according to Mandriskaya and hence 2019, higher education institution, we can see that has place of learning and teaching where it involves a lot of emotion. Yeah. So because of this, you know, we want to know how do the students feel, because we conducted online learning, we are asked, we are forced to carry out online learning, but we want to know how do the students feel about online learning. Yeah. So it is important that we listen to the students' voices in order for the online learning to be successful. That's why we did say earlier that the lecturers and the students should co-create. No? It's not like it's one way where the lecturers prepare and just deliver. It cannot be that way. It will not be. Okay. So, the next one, please. Right. So, I have actually conducted a very small scale study. Actually, this is something that I think I should look into. Yeah. Okay, I teach the writing skills. Okay, okay. In this course, what they need to do is they learn the various types of genre. So what I asked them to do is I gave them a question: what do you feel about online learning and then learning on the computer? Okay. So I asked them to write an essay. So there were 80 of them. Okay, find out how they feel about online learning. Okay. Okay, next. Okay. Based on this, they have given their feedback, and some of them feel that this online learning can be fun because they say it's fun learning. Yeah. And then some say that, you know, you can be far away from each other. Some of them may be on the Borneo Island. We have students from there, Sabah and Sarawak. And they say that they can be thousands of miles apart, but they can still stay connected. Okay? And not only that, they say that this online learning, although you are not on campus, yeah, although you are not on campus, but you can still access the class, so it's okay. And then number 4, you can see that some of them said that this online learning is very flexible. Okay. Now I cannot deny that, okay? Because as the head of the department, I have a lot of meetings. So sometimes I have to reschedule my class. I have my class at night where I am accessible. Some of the students, they work in the daytime and then we have the lectures at night. Some of them, they have things to do at night, so we do it in the daytime. So it's really very flexible. Yeah. And on top of that, some of the students feel that online learning is very cost effective because say for their transport, we have buses where the students have to pay for the transport, and then the students are from all over the country. Then when they come to Tanjung Malim, where our campus is, they have to pay for their house rent. Yeah. And they have to pay for their food. But when they live at home, their parents will pay their and not have to travel. They just attend class in the vicinity of their homes. So they say that it is very cost effective. Yeah. Okay, next. These are the next slide, please. Okay, these are the extract of what the students say. This is taken, all these extracts are 30 minutes that's given to me, but basically you can see that I have bold some of them, say that studying is more fun, and then it's different because each class feels different and fresh, yeah. And then after that, their teacher to convey their message or teaching their students, they cannot be alone. So they can still stay connected, and then people can have a meeting online without even meeting. So they say you can still stay connected. Okay, next. Next slide, please. Okay, so there it said access education. We go back to the previous slides. Okay, you can see that they say that, you know, as long as good internet connection, you have accessibility. And then they say, this is very interesting. More people will have the opportunity. As long as you have internet access, it's okay. And students can be able to flex their schedule, and there you see they say it is very flexible. Yeah. Okay, next slide, please. Okay. You see classes use less facility, no hostel rent, no other fees. So it's very, very cost effective. Okay, let's look at the next one. Okay, this is what they feel about, yeah, so that's many, as you can see there are 7. What don't you like about online learning? Say it lack a real relationship, and then lack of interaction, a real interaction, because you can't really be close to each other. And then in terms of education, they say that there is a lack of focus, because you cannot focus on your study, because in the classroom the lecturer will be there all the time, they are not focused. Okay, and then they also said that there is lack of attention from the lecturer. Okay, I experienced this. You have like 50 students attending the class at the same time. Okay, you give your lecture. How do you know that they are all listening to you? How do you know that they are there? Students at random. So it takes up a lot of the time. Okay, and students sometimes they feel that they don't know, so they want to know from you. They want the attention. In class, they can just put up their hands and ask questions, but it's quite difficult to do that. As you can see just now, in this presentation, it's very difficult for the participants to ask questions and to know. The students feel that you are not there, so you are not getting all the help from your lecturers, and sometimes they are not getting the help from their friends as well, because they work together, you know, they are very close, they work together, they learn from each other, and they are not getting it. And according to them, it is also not the, and they need to have a lot of data. Yeah. I use my telephone at the beginning of the movement control order in March this year. And you know, for 1 hour, if you talk 1 hour in the classroom, at the virtual class, you can see that your data will all be used up. Okay? Say that, you know, you have health issues. Because, you know, for us, we only give a 3-hour lecture, and we don't give 3-hour lectures because accordingly, 7 minutes is equivalent to 1 hour, right? So here they say if you stay very long on the computer, you work on the it is not good, and then you tend to eat, so you get obesity, right? Okay, can we look at their responses? This one I have actually gathered all the things and put it together. Yeah. Okay, next, please. Makes us feel alone, and then it lacks direct human contact or interaction. So there's no real relationship here. Okay, next please. Very interestingly, because you gave me only, yeah, okay. So you see, technology has brought real life communication, and it can never replicate in the presence of the person, okay? And then there's no interaction between the peers and the instructor, and you can see that the students' feedback is very limited because of the time, because there are 50 students in the class, okay? So the students, is very difficult for them to give. Let's look at the next slide, what they say. Why didn't you like about online learning? Can we have the next slide, please? Hello? Yeah. Okay, here. Some of them, they don't understand the topic. You see, in a traditional class, they can actually ask the side yes in the chat box, or they just switch on their microphone and they say yes, they don't understand. But in actual fact, they do not understand. You know, they do not understand. You know, in a traditional classroom, sometimes the students will approach you individually, and then they will tell you what they don't know, and they want clarification at them. So some people, they feel very intimidated. Yeah. So in the end, they don't learn anything. They don't know, they didn't ask, and we lecturers, we don't know whether they know, and we carry on. So that is actually very bad. And then here, this one is interesting. It said, listening too much information at the same time without engaging, being very honest here. Okay, they tend to get very sleepy in class. When they are tired, you ask them to go to the ladies, the gents, ask them to wash their face. But when they do online, they switch off their camera, so we don't know what's happening to them. And then, you know, there's lack of focus. Yeah, in class they will get, and yes, okay, and hello, yeah, okay. Can we go to the next slide, please? Yeah. Okay, here they said that they feel lost without the direct assistance from the, they say during the assessment period, cheating, it's very, students tend to cheat. You don't know whether it's their work, and then they go online. You don't know whether it's their work. You don't know whether they're cheating or it's truly their work. Yeah. Okay, next. So this is a long one. This is what the students said, but I've highlighted. It said that students they have a hard time to ask lecturers about the following when they didn't understand. In contrast, the face-to-face class, students can directly ask the teacher, and there are two-way communication. All right? Okay, next, please. At our university, we are encouraged to give students individual work, pair work, group work. So here they say if you give the group work, then it is very difficult for them to go online to actually do group work. Yeah, and sometimes there will be friends who are not free. They do not to be done in online learning because not everyone has good internet connection to partake in group discussion. That is very true. Yeah, because some areas like yesterday, my students, they need to present, and they say, "Doctor, I'm so sorry, there's blackout, so they cannot go online." And they say, "Doctor, so sorry, we have." So all these glitches, it's really affecting online learning. Okay, next. So it is very interesting to know how they feel. Okay, so if you say that it is not, it is cost effective, according to them, it is not. Why? Because they have to pay for the data. Okay, eyesight, and you know this one. You see, you can lead to obesity, stress disorder, and high risk of blood clots. So they read, and all the online learning, it may lead to health issues as well. So the students, they are very concerned. Okay, next please. Learning match your experience in an actual classroom. According to the students, face-to-face is so much better than online learning. Okay, and some of them say that online learning is not as good as face-to-face learning, and then high rate of withdrawal online course. Why? Because they feel that they are not learning anything, and then they say they are bad examination scores because they don't learn much, and then it is not cost effective because they still need to pay, and then the interaction between the peers and the instructors are truly lacking. Yeah. Okay, next. The students have said that face-to-face is far better, and then after that they say that the withdrawal rate, like I said just now. Okay, next. This is the comparison. Yeah. Okay. In 2015, facial expression, sometimes, you know, it's true. Now, you don't even know how I'm feeling, you know. I don't even know how you're feeling. Maybe you're bored, maybe you learn something from here, but I don't know. Why? Because there's no facial expression, there's no hand gestures, okay? And then here, if it's face-to-face, then you have two-way communication, but not on online learning. And then here, one student wrote, I strongly oppose the idea of online learning. If you say that it's as good as face-to-face, he said it's not. Okay, next please. Okay, so and then face-to-face, you will concentrate more and you can understand more. Okay, next please. Okay, so what are the challenges of online learning? One, we have to make sure that students, they have their laptops, they have their smartphone at least limited, and then not only that, we have to look at the disparity in Malaysia. I don't know about Indonesia, but in Malaysia, sometimes the internet connection in the rural areas are not as good as the connection in the urban areas. Yeah? So here, and then in exam also, you know, every year the university has already planned their schedule, and online learning has actually disrupted the schedule. Yeah. Okay, these are some of the challenges. Okay, next. Okay, next. Okay, now there are many vigorous slides before this. Can I have the slide before this? Yeah. Okay, so you see there are so many studies about the impact of online learning on students and then face-to-face teaching and learning. So here the students said that sometimes, you know, glitches, you know, they tend to ask questions, a lot of questions, they tend to shout, so it sounds very offensive. Yeah? And then they cannot enjoy the time that they have in the lecture hall, and then it is not really conducive to hold debates and discussion, and they have from each other, you know, and they're not getting it. So these are some of the challenges. Yeah? Okay, next. Okay, my conclusion is that there are many kinds of learners. So if we want to conduct, you know, we want to conduct online learning, we have to be creative, we must know how to use technology, we must be good in all these technological aspects. And then the classes should be small. My experience when I did my blended learning in the US, the classes were really small. About 10 people or less than 10 people. But the classes that I have now is about 80 people, 50 people. So it's really very difficult for everybody to participate in classroom discussion, to, you know, to really give our opinion. So it's really very difficult. Okay, for the instructors, yeah, for the instructors, at my university, there are a lot of courses, yeah, and workshops, how to conduct online learning lectures, how to conduct, you know, your lessons on online learning to make it very interesting, make it fun. Okay, so lecturers, you cannot just use one method because the students said that it is very boring. So you need to find out what are the ways to, you know, to make your class very interesting. So you have to come up with your own videos, you have to come up with your own recording. Actually, it's more work for the lecturers. That I can see. Okay? Right. Next, please. Okay, so my recommendation is that we need to conduct more studies on what online learners need. Okay, is the need analysis, and then why online learning failed in some cases, and then this is a new norm. How do we make online learning work for everyone, even if they do not have access to the internet? What do we do? And then what are the alternatives to online learning? How do we deal with those without computers, those without internet connection, those without the tools? How do we deal about, because I think even with the vaccine, I don't know, maybe the doctors don't agree with me. Even with the vaccine, we are not sure when this pandemic will actually stop, when it will cease, because there was a question asking the doctor, when will this pandemic stop? Even the doctor cannot give you a definite answer, and nobody can give you a definite answer. Although everybody claimed that they have come up with the vaccine, I read in one article that, people take vaccine in Korea and they died. So we don't know. We really don't know. So these are some of the things that we should look at, we should study in order to help the students. And the last one, you can see that there's the disparity between the rural and the urban areas. So how can we help those living in the rural areas? Because I got students in my class who cannot actually attend the lesson at all because of their internet connection. Yeah. Okay, next please. Okay, my last word is that lack of communication with teachers and students, the performance of the students participating in online learning is not satisfactory, and then the efficiency is also very poor. That is what Minhu enrolling in 2017 find out. Okay, thank you very much. I am open to discussion. Yeah, these are some of the works that I have referred to, but most of it I refer to my students' work. Yeah, okay.
Thank you very much, Dr. Hasima Jafar, for the wonderful presentation about students' voices on the COVID-19 pandemic. Ladies and gentlemen, for the next, I would like to invite the second speaker of this session. Will be delivered by Mrs. Pregiwati Pusporini, PhD from Universitas Muhamadiyah, Gresik. And before her speech, I would like to read the summary of her CV. Mrs. Pregiwati Pusporini, PhD, is the Vice Rector for Financial Affairs of Universitas Muhamadiyah, Gresik. She is also the lecturer of the Industrial Engineering, UMG. Her educational background, she got her bachelor degree in Industrial Engineering from ITN Malang in 1993. Her master degree in Industrial Engineering is from ITS Surabaya in 2002. And she got her doctoral degree from School of Engineering, University of South Australia in 2015. Her research interest there are some of her research interests. Everything is about technology, and she also got many grant research from Indonesian Ministry of Research, Technology and Higher Education. Mrs. Pregiwati is also writing some publications, the reviewer of a journal, and active in presenting seminars and workshops. Okay, good afternoon, Mrs. Pregiwati. Are you here with us?
Okay.
Okay, good. How are you today?
Good, fine.
Yeah, Mrs. Pregiwati, you have 30 minutes to present. The time is yours.
Okay, thank you. Terima kasih, Ibu Nia. Hello everyone. Assalamualaikum warahmatullahi wabarakatuh. My name is Pregiwati Pusporini. I'm from Universitas Muhamadiyah, Gresik, and my background is industrial engineering. I'm glad to be here today in a great event, International Conference on Engineering, Science and Technology 2020 that hosted by Universitas Muhamadiyah, Gresik 9 to 10 December 2020. Today I want to share my experience, my research experience related to a conceptual framework of cold chain and sustainable indicators of cold chain performance measurement. Recently, the concept of cold chain has been growing rapidly all over the world. Many research, many discussions have been conducted related to the concept of cold chain. If we talk about the concept of cold chain, the first question in our mind is what the difference of this concept with the supply chain management? Is this concept need a specific requirement? In a simple word, we can identify that cold chain system is a type of supply chain where the main aim is to maintain the product's temperature during the distribution process. And next, what kind of product that need a cold chain management? A main concern of cold chain is perishable product. That means this product need a special treatment, especially related to temperature to keep the freshness and also to keep the quality of the product. Mostly, food product need a special treatment related to product temperature, such as meat, fishery product, fruit, vegetable, some medicine and drug product like vaccine. Okay, how about the food product? We can see in here that the value of loss and waste of food product in the world achieve around 1/3 of the global production in terms of weight. So this is a big number. So to deal with this issue, we need a better utilization so we can maintain the freshness and the quality of food products starting from the raw material until the end of the customers. If we discuss about cold chain, we can identify this concept into three perspectives, like cold chain as a science, cold chain as a technology, and also cold chain as a process. Firstly, the meaning of cold chain as a science refers that this concept needs the understanding both of chemical and biological process related to perishability. And secondly, the meaning of cold chain as a technology refers to that this concept depends on the physical means to ensure suitability temperature circumstances alongside the supply chain. And lastly, the terminology of cold chain as a process indicate that this process consists a set of tasks that have to be performed to arrange, to store, transport, and to monitor temperature for sensitive product. Okay, another question in here is what the basic element of cold chain? There are 4 basic elements of cold chain, such as cooling system, cold storage, cold transport, and then cold processing and distribution. And then what I'm going to do now is I want to share my research related to a conceptual framework of cold chain and sustainable indicators of cold chain performance measurement, particularly for fishery product. Why fishery product? Why I choose fishery product particularly in Indonesia? The main reason I choose fishery product in Indonesia because based on the data from the Ministry of Maritime Affairs and Fishery, we can see in here that fishery production in Indonesia is increasing. We can see from 2011, production of fishery product achieved around 13.64 million tons a year. And then we can see that this rose sharply in the fourth quarter of 2017 to reach a production rate around of 23.51 million tons a year. And also, fishery sector is Indonesia is one of special concern that has a contribution to the economic development. And another reason is fish consumption in Indonesia also increasing. We can see in here in 2014 the initial average was only 38.14 kilogram a year and increasing up to 46.49 kilogram a year. Fishery product as one of perishable product need to be treated appropriately to keep the quality. Otherwise, it causes many losses such as excessive maturing, weight loss, softening, color and texture change, physical degradation and bruising, and also attack by root and mold. So if this happen, will impact to the freshness, impact to the desirability, and impact to the marketability of the fish product. Okay, next. So the methodology for my research, some literature review has been conducted, and then a deep discussion with some expert and stakeholder related to fishery business and also related to the cold chain methodology. A number of literature review have been conducted to guide the identification of main component of cold chain. We can see in here there are many factors from literature review that point out key factor for cold chain implementation, such as poor logistic infrastructure, shortage of cold storage, lack of refrigerated carriers, lack of incorporation, grid cost, and lack of information sharing up to government regulation. If we're doing research about cold chain, we have to realize that this research area is very broad. So we need to make a limitation of research, so the research is reasonable to be applied. In my research, we classified main component of cold chain implementation, particularly for fishery product, into three main components, like a government, main industry, and sub-industry. Main industry in this research refers to the fish processing industry itself, while support industry or hub industry refers to the industry that support the cold chain implementation. Why I put the government as a main component for cold chain implementation in this research? Because there are many functions of the government for the cold chain implementation. The government takes an important role in the implementation of cold chain related to the regulation, facilities development, and also information system. Government regulation influence on many aspects such as annual catch quota, monetary policy including interest rate, policy on the use of facilities like fishing gears, ships, licensing policies. These factors have significant impact to the fishermen and also their capability to provide fish product. For example, the regulation of monetary policy will impact to the financial capability of fishermen to survive in their business, related to how to provide a ship, how to provide their maintenance costs, how to provide their financial to provide enough fuel, enough ice, and so on. And what is more, in the development of facilities, government plays as a trade facilitation, port facilitation, fuel supply, ice supply. For example, how the government provide appropriate ports with their facilities to support fishery business. How the government guarantee on the availability of fuel and ice to support the implementation of cold chain. At the same time, government takes an important role related to the development of information system. For example, by using the satellite technology, government provides information related to on weather prediction, seasonal catch prediction, and also stock availability. This information has many beneficial for the fishery business, so the fishermen can create an appropriate schedule when they have to catch fish, in which area, and what kind of fish they will get. The government, as one of main component of cold chain implementation for fishery product, is divided into sub-components such as education program, proper organization, facilities for supply chain members, infrastructure, IT, and standard definition. Okay, next. The second factor of conceptual framework of cold chain implementation is main industry. In this research refers to the fish processing industry itself. These factors will include transportation, cold storage, and ships. Transportation will cover the type of transportation used, reliability, capacity, and cost, and also as efficiency. Transportation is an important part of the cold chain concept. An appropriate transportation will guarantee the quality of fishery product and ensure their freshness and safe for consumption when they reach the destination market. The type of transportation used include the selection and provision of cold storage as well as the selection and supply of ships as the means of transportation. Meanwhile, cold storage in here includes several aspects. For example, how the design of the cold storage, because the design will influence to the capacity of cold storage. How to design and set the cooling materials. How to guarantee the availability of cooling materials. How to provide enough power in the cold storage to keep the freeze temperature. And also how the total cost that have to be spent as an initial investment to provide appropriate cold storage and their efficiency. Similarly, the type and size of ships used determine their capacity, the cost that have to be provided, efficiency, and also their reliability to support cold chain implementation. Then lastly, the main industry is divided into three sub-components such as export, consolidation of supply chain member, installation and operational expenses. Expert in here refers to someone who has knowledge, who has expertise and experience related to the cold chain implementation, related to the fishery business in Indonesia. And then the third main component of cold chain implementation is support industry, that refers to industry that support the cold chain implementation, like the existence of ice factory that will be able to provide and supply ice cube as a cooling material for storing fishery product. The cold storage rental industry as a mean of storing fishery product, and the availability of transportation, including containers and trucks to support the cold chain concept as of fishery product. Similarly with the main industry, the support industry in here will be divided into three sub-components as well, like industry, like export, supply, consolidation of supply chain members, and also installation and operational expenses. So we can see in here, based on the classification of main component of cold chain implementation, we have three main components in here: government, main industry, and support industry. Based on the measurement from analytical hierarchy process that use asset per-base comparison, we can see the value of three main components. We can see that the main industry achieved the highest score with the value of 0.419, and then followed by the support industry and government aspect respectively. Whereas in the main subcomponent, fish processing industry, it can be seen that the cost for installation and operation occupy the highest score value, that is 0.520. This shows that fish processing industry emphasizes that the amount of cost they must bear in connection with the implementation of the cold chain concept is a very dominant factor. The second subcomponent is the consolidation and coordination of all members of the supply chain involved by 0.343, and the third subcomponent is the availability of experts in the application of the cold chain concept in the rate of 0.239. The second component, support industry, consists of three sub-components, namely the availability of expert, consolidation, and cost or expenses. Based on these three sub-components, it can be seen that the installation and operational expenses also occupy the highest position, with the value 0.623 and followed by the export availability and consolidation of supply chain members of 0.239 and 0.137 respectively. The third component, government, are divided into 6 sub-components like education program, proper organization, facilities, IT, infrastructure, and standard definition. Based on the 6 sub-components, it was found that the facilities achieved the highest score with the value 0.357 and followed by infrastructure, IT, standards, proper organization, and education program with a value 0.265, 0.150, 0.108, 0.073, 0.048 in sequence. So we can see summarize the value of each component and sub-component from the measurement from the analytical hierarchy process. There are some highlights in here related to the implementation of cold chain, particularly for fishery products. The percentage of fish losses reached an average 30% due to several things, like fishing fleet of 85% dominated by small-scale fishermen without equipped with cooling facilities like ice cool box, and the trip time is quite long because the fishing ground is so far away, and then landing facilities and fish auction that are not or less meet the standards, and also lastly no or lack supporting facilities such as ice factories and supplies clean water. Okay, next. Okay, and now I want to show the second result of my research that related to the sustainable indicators to assess the cold chain performance measurement for fishery product. If we discuss about cold chain, research area about cold chain that also challenging today is how cold chain is connected with the sustainability. If we talk about this sustainability, we can see in here about in around 1987, the World Commission on Environment and Development introduced the concept of sustainable development. Furthermore, in 2002, sustainable development was termed as involving 3 fundamental dimensions, namely social, economic, and environment. The identification of sustainable indicators will be challenging since it is still arguing to have a set of sustainable indicators which are applicable and appropriate to any industry. Not all of the indicators are good. Some of them are hard to measure, others have no meaning to the local community, and some are difficult to understand. We can see in here that some criteria that have been suggested by now for sustainable indicators such as measurable, relevant, understandable, reliable, data accessible, timely manner, and long-term oriented. Okay, we can see in the slide in here the summary of the sustainable cold chain indicators that consists 3 dimensions like economic, environmental, and social. The first dimension of sustainable is economic, which consists three aspects such as cost, availability, and service. Sub-indicator costs including operation costs, investment costs, staff and training costs, also inventory and distribution costs. Many researchers highlighted that the cost plays as a significant role in implementing sustainable cold chain. Even the concept of sustainability and cold chain has been growing spreadly all over the world. The implementation of this concept is still far away from the satisfaction. Once industry commit to apply cold chain along their production process, they need to provide some of cash related to investment and operational costs. For example, how they provide a cooler box to keep the freshness and quality the fish product, how they manage the availability the power, how they guarantee the availability ice blocks, and so on. At the same time, the industry need to improve the knowledge and competency their staff related to cold chain implementation. For example, how they provide training and workshop to improve labor skill and knowledge related to cold chain implementation. And then next, the availability will include the availability of all necessary resources such as product availability, payment availability, and required cash flow, operating hours, short lead times, and the availability of other resources. Service in this research will related to how to provide products that meet with the quality standards, and then how the process of product is linked to the implementation of environmental management system or ISO 14000. The second dimension of sustainability is environment, which covers two main aspects, namely process and resources. Once the industry concerned on environment, they need to pay a big attention in their process and their resources in environmental friendly. For example, how their process and circumstances produce less pollution or zero pollution, and also how the industry concerned on the sustainability, the fish stock at the sea. And then environmental aspect in this research, we can see that this aspect related to the process carried out, whether it will have an impact on water pollution, air pollution, and resulting the waste. In addition, whether the marine resources and the sustainability of fish in the sea will also be affected. This emphasizes that the environmental sub-indicators related to resources include the potential for marine pollution and the sustainability of its resources in the oceans. And lastly, resources will include marine pollution and fish sustainability. And then the third dimension of sustainability is social, which consists three sub-indicators, such as occupational safety and health, proportional organization, and working condition. Okay, we can see in here the result comparing the three dimensions of sustainable indicators for cold chain performance measurement. We can see that the economic dimension achieved a highest point with a score 0.625 and followed by environment and social dimension respectively. This indicates that the performance measurement of cold chain implementation emphasizes the economic dimension, which divided into three indicators, namely cost, availability, and service. So if we look at a more detail in the economic dimension, we can see that the top point of indicators is cost, with the score is 0.540, then followed by service and availability in sequence. Next, for the environmental dimension, we can see that the highest point is process, with the score is 0.750 and followed by resources. This indicates that the process along the cold chain implementation has to be considered carefully, as it has a significant impact to the environment. And for the social dimension, we can see that the top point is working condition with a score 0.493 and followed by Wealth and Safety and Proportional Organization in Square. Next. Okay, we can see in here the sensitivity analysis. We can see that economic has a significant impact to other value of sub-indicators. Once the economic indicator is going low, for example, below than 0.45, then this condition will impact on the value of waste pollution. On the other side, if environment aspect change, this condition will impact to operation costs and also to waste pollution. Okay, next. Okay, the last part, conclusion. We can summarize my presentation today into a conclusion. Firstly, the key success factor for the cold chain system consists three fundamental factors like government, main industry, and support industry. There are some highlighted that have to be concerned for fishery business in Indonesia. Firstly, a strong collaboration and commitment between government, main industry, and support industry is needed to provide the availability of cold chain infrastructure and facilities such as cooling facilities, ice factories, supplies clean water. Secondly, some programs need to be set as a target for the implementation of cold chain for fishery product. The priority of this program on how to accelerate implementation of cold chain start from on board, introduction the use of cooling material at landing center, facilitate port with cold chain support like as ice factories, cold storage and chilling room, and clean water supply. And lastly, the consideration of the availability of laboratory facility, processing and quality testing on port to deal with the import processing requirement and also to meet with quality certificate both nationally and internationally standards. Okay, that's all my presentation today, and thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi. Yeah, thank you very much, Ibu Egi. Okay, ladies and gentlemen, our presenters already did their presentation. Now we are coming to the discussion session. Please either raise your hand so that the committee can unmute your audio, or please write your question at the chat window. You have 30 minutes for the Q&A sessions.
My question?
Yes, please.
Okay, thank you very much for the time. I'm Wahyu Dewi Swistiarini from Kasiyata Husada Samarinda. Thank you very much for the speakers today. It is very great presentation and also information for us. And my question for Dr. Hasimah that talk about education system and learning process. Because my background is nurse, so we focus on how to achieve clinical competencies. According to your opinion, if we talk about online learning process, or what kind of best method to achieve the clinical competencies for our students? Thank you very much.
Okay. Can I answer? Yeah, okay. You want to know about clinical. And can you, the question was not that clear of the background disturbance. Brief. what is it that you want to know? Yeah, I heard about something clinical. Is that what you said?
Yes, clinical competencies.
Okay.
Because in this pandemic, during this pandemic, we use online learning, right?
Yes.
So we were concerned to how to achieve clinical competencies, because right now the best approach is we meet directly with students. So maybe you can give some suggestion for us how the best method for us to teach and to achieve clinical competencies for our students.
Okay. So one of the things that we can see is that we got no choice. During this pandemic, in Malaysia, for instance, the government closed the schools because, you see, we take COVID-19 very seriously. If one person is infected in a school, the school will be closed because the whole school, because of the contact, they will do a swab test on everyone that is in contact with the person who is infected. Yeah. Okay, that is one thing. So in terms of study, if you want to talk about clinical study, I would say that it is very difficult for us to meet the students face to face, because especially now in Malaysia, what we do is that the government actually identified an area. If you have like 50 people infected in one area, then that area will be labeled as red zone. So red zone, you cannot go out, we cannot go and visit you. So most of the studies conducted now, we will do it online. Okay, like my study, I want to know the learner's need. All I did was I have to prepare Google survey, you know, and you just give it to the teachers so that the teachers can give it to the students. As it is now, it is very difficult for us to collect data in person. In fact, our PhD students, our master students, most of them, they have to defer their studies if they need to go to school to collect data. Okay. Now, for instance, as it is now in Malaysia, all the schools are closed. So it is very, very difficult for you to collect data if you need data from schools, if you need data from students. Even at our university, we are doing everything online. We do not allow the students, we don't encourage the students to come back. Okay? So everything is done online, but in UPSI, they have a lot of help for the lecturers, whereby the lecturers are taught how to use technology when teaching. But whether or not it is used is another thing. Okay, but we are given the courses, we are given the workshops, how to conduct the lessons online. Okay, as it is now, I would say that this is not the best time to do, clinical study where you need to see the students in person. Yeah.
Okay, thank you very
much. Does that answer your question?
Yes. Bagaimana Ibu Wahyu?
Yes, Dr. Hasima. And what do you think about laboratory when we want to do learning process using laboratory, like we want to practice something, what kind of thing the best approach for us to teach in laboratory clinic?
Okay, right. In UPSI, what we do is we allow students to come back if they need to use the laboratory. Okay, but of course we will follow the standard operation procedure, whereby they have to use their face mask, they have to be, the social distancing, but they are allowed to come back and do their work at the laboratory. Okay, but you must abide by the SOP. That's very important. We make sure, before they go in, they have to make sure that they have to scan their temperature, they need to use the sanitizer, and then normally they will not stay that long in the laboratory. That is how we do. But we do allow. What about Indonesia? do you allow the student to use the laboratory?
Yes, but we use COVID protocol for doing laboratory.
I think that
learning process.
That is standard everywhere. I think that is the best way to do it. Okay, but we only allow those who needs to use the laboratory, because you know, we don't want so many people to get exposed, because it is not good. You know, it is not good in the sense that the virus cannot be seen, so we cannot actually we don't really know how to deal with the virus. You know, that is the thing. So we try to limit the number of students who will be, you know, who will be allowed to be in the vicinity. You're very enthusiastic. Okay. So, Nia, do you want to read the question, or do you want me to read the question? Because there are some questions there.
Okay, yeah. Thank you, Dr. Hasima. There are some more questions for Dr. Hasima. There is a question from Bapak Tri at the chat window. I'm going to read the question.
Can you please read the question? Because there are many questions.
Yes, yes. Pak Tri from Pak Tri Yuli. Pak Tri Yuli. He is a teacher at Universitas Muhamadiyah Gresik. He asked, you mentioned about teachers have to be able to use technology well in online learning, but did you happen to find problems or maybe solutions to solve technology usage from the students? Because in my experience, some of my students lack knowledge in using technology for online learning. Yeah, that's his question, Dr. Hasima.
Yeah, okay. Bapak, the fact is I am teaching at university, and most of my students here, they are well versed with the use of technology, and the technology that we use are actually very simple. We use Google Meet, we use Webex, we don't use Zoom, because Zoom, there was some kind of problem before this. Most of the time we use Google Meet. So it is very simple in the sense that, you know, the lecturers, we have set the date and the time. All the students need to do is just to log in, and they are already in the classroom, in the meeting. Okay, in school, I think one of the things that you need to do is you need to teach your students to use the gadgets, you know. If they are using the smartphone, how do they use the smartphone to enter the class? If they are using laptops, how do you use the laptops to go into the class? I would suggest that the teachers don't use something that is very complicated. Use something that is very simple, okay? Like Google Meet is free, and also Google Meet, you can fit in about 100 people. So I don't think your class will be having more than 50 people. So the use of technology is very convenient actually. But I would suggest that when you conduct your online class, when you know, especially in school, you need to go slow, okay? If your class is big, okay, let's say if you have a class of like 40 people, I would suggest that you divide your class into two. So maybe the first 20 can go into the first class, and then the other 20 will go in the second class. Okay, that way you can ask all the students questions one after another. If you have so many students in the class, then it will be very difficult for you to handle the students, and it is not fair, because, you know, from my experience, if you use Google Meet and everybody switch on their camera, then the camera, you know, the one thing, they cannot get access, you know, some people cannot get access. So I would suggest that make your class smaller, okay? But you have to work extra hard. You have to conduct your classes one after another. That is what we did. That is what I did.
Okay, thank you, Doctor. The next question is still for Dr. Hasima. It's from, I'm so sorry, Bapak or Ibu Barotun Mubaro from PGRI Wiranegara, but he or she didn't mention the question either at the chat window. Okay, so now I'm going to the next question, still for Dr. Hasima. It's from Ibu Dahlia. So here what she wrote. I'm the assistant from Dahlia Kusuma Dewi from USU. Want to ask the first speaker. As we know, during this online learning, students complain because this online learning is not effective because students cannot understand learning well. Got minus communication, cause the limited internet too. Although they always respond with yes when the teacher asks so. What do you think about it? What should to do for this online learning from the government or from the student or from the teacher to find the solution? Thank you.
Yeah. Okay, one of the things that we have, when we use technology, there are problems. Like I have mentioned just now, sometimes they do not have access to the internet, sometimes they do not have the tool. Okay, so one of the things that teachers can do is you cannot go as fast as when you are teaching face to face. So I would suggest that you have something like a module, something like a module. So make your class smaller, make your class smaller. But like I said, you have to be more hardworking in the sense that if you have a class of 40, maybe you can divide the class into 2, and instead of going to class once, you have to go to class twice. Okay, so do not, you have to understand that online learning, 7 minutes of lecture, teaching, online learning is equivalent to 1 hour. So what do I do? Normally, I will teach my students the concept, whatever needs to be imparted for 7 minutes or 10 minutes. Then I give them some exercises. Okay, some exercises, give them like 20 minutes or half an hour, and then come back and we check the question. And then we look at some questions again, allow them sometimes to do their work. So it is like in class, the only thing is that it is done online, but the teachers must be there all the time. You have to call the students. That's why make your class smaller. If your class is smaller, you can call your students. I always call my students. I post a question and then I will call my students one by one. But I will give them time to find the answers. Okay? Normally in Malaysian schools, we don't allow the students to bring their telephone. Alright? But for online learning, let them use the telephone. Let them find the answers. Okay. I know Malaysia and Indonesia, we are not the same, especially there is a disparity. We also have problem whereby in one family, you have only one laptop and you have 4 children to use the laptop. Okay, that is a problem. I think that problem is everywhere because not everybody can afford. Alright. So in Malaysia, in my university, for instance, if we know that the students, we find out from the students, do they have internet access or not? If they don't have internet access, we will record our lecture according to the 14 weeks, and then we will save everything in a flash drive, in a thumb drive, okay, and then we send it to the students so that they can follow the lectures accordingly. And then after that, we give them the assignment, and they will post the assignment to us. Sometimes in Sabah and Sarawak, they have problems. They have problems. So what they did was, they will do their work, and then we will set a day where we will talk to them. Okay, so they will have to find internet access. Right? I hope that answers your question. Okay, you have to be creative. That's why I said the teachers must be creative. You cannot depend on the government. You cannot depend on your school to, you know, to do the work. You will have to investigate. You will have to find out how to make your class more effective. Okay, because different location will require different kind of solution. That's my answer to your question, Budalia.
Yeah, thank you, Doctor. I'm so sorry. This one is the question from Ibu Barotun Mubaro. She wrote, "I have been observing my."
Is there any more question?
Sorry. Yeah, one more question for you, Dr. Hasima. Hello? Yeah, can you hear me, Doctor? Yes. This question is from Ibu Barotun Mubaro at the chat window. She wrote, "I have been observing my students' behavior on learning online during this pandemic. They were very enthusiastic in the early stage of the course, but they were becoming reluctant to follow the rest meetings of the course. How can you see this phenomena? What can you suggest for solving this fact? Thank you, Ibu."
Okay, right. One of the solution you can do is do not teach them for 1 hour. Okay, do not teach them for 1 hour. What you can do is you divide. If it is a 1 hour lesson, you divide your lesson into segments. You give them explanation and then give the question. Okay, and then after that, come back to the class, ask them to present. You know, there are a lot of ways that you can do it. You can ask them to present, you can have question and answer, you can have debate. There are a lot of things that you can do. But my suggestion is that, like, I cannot solve your problem, but I'm just giving you the suggestion. What you can do is you segment you compartmentalize your lesson. Okay, don't give 1 hour lesson, you talk and talk and talk and talk. Of course, they get very bored. Yeah? So make sure you give it 10 minutes, and then the next 10 minutes ask them to do something and exercise or something, and then the next 10 minutes get the answer from them, and then and also, have you ever heard of flipped classroom? Flipped classroom is when you give the students something to read in advance, so that when they come to class, they are more well versed, they know, and then you can ask questions and the discussion will be better. Rather than you teach, you give it to the verse, and then after that, when they come to class, you talk. Do not teach your online learning like you are teaching in class. Okay, because it won't work. It won't work. You have to make sure that you ask questions, you ask one by one. That's why your class must be smaller. That is the first thing that you must do. Okay?
Yeah, Dr. Hasimah, thank you very much. And I'm so sorry for the participants. We cannot read all of the questions as we have to over the discussion soon. It will be 5 more left. There is one question for Ibu Egi. The question at the chat window is from Bapak Abdurrahman Faris. He is from Universitas Muhamadiyah, Gresik. His question is, how do you implement in the cold supply chain for traditional fishermen who are currently still problem with technology? Not to mention government policies that still do not support traditional fishermen. Okay, Ibu Egi, the time is yours.
Sorry, Bunia, can you repeat the question, please?
Oh, okay, yes. The question is, how do you implement it in the cold supply chain for traditional fishermen who are currently still problem with technology? Not to mention government policies that still do not support traditional fishermen.
Okay, thank you. Like I mentioned previously in my presentation, that if we talk about cold chain management system, this research area is very broad. So I make a limitation research in here. We classified a main component for the cold chain implementation, only 3 main components, like government and means industry and support industry. In my research, I did not mention about the fishermen that involved for the cold chain implementation. But I mentioned previously that the government plays many functions for the cold chain implementation, like how the government provide information system so the fishermen can use this information to guide them, and then to arrange the schedule time when they have to catch fish, and then in which area, and then what kind of fish that will they get. And I think the fishermen in the cold chain implementation has a significant contribution, because main industry mostly collect the raw material from the fishermen. For example, fishermen send the fish to the auction, and then maybe main industry that refers to the fish processing industry collect the fish product from this from the fishermen, and then they process, and then they send to the their plant, and then they set to the transportation, and they set to the cooling box on to keep the freshness and to keep the quality of this product. Is this answer your question, Pak Faris?
Yeah. Thank you, Ibu Egi. There are 2 more questions for you, and this will be the last questions from the participants. The second question for Bu Egi is from Bu Cici at the chat window. She wrote, this is very interesting for sustainability. As we know, this technology very urgent to preservation. My question is, how to make it easier, and how is the solution? Thank you.
Okay, thank you, Bu Cici. Maybe in the last part of my presentation today, I mentioned the suggestion in my research for government, and then for main industry itself, and also for the support industry. Because when we talk about cold chain implementation, we cannot say that it's only the responsibility for the main industry itself, but this is need a strong collaboration between 3 main components, including government, including main industry, and including support industry. For example, why the government plays an important role in this implementation of cold chain? Because many functions that can be provided from the government. Like I mentioned previously, like policy of the monetary policy, and then how the government provide definition of the quality of the standard of the process of the product related to the cold chain implementation, and then how the government provide education program to improve the understanding the concept of cold chain to all stakeholders, and then also how the government provide proper organization. That means how the government set a clear definition of tasks, a clear definition of responsibility, and a clear definition of authority to all departments related to the implementation of cold chain. So I think this is need a strong collaboration between three main components I mentioned before. So we can say that this is only the responsibility of industry, no, but the government should take a role in this, in the implementation of cold chain. Okay?
Yeah, thank you, Ibu Egi. Now the last question that will close our discussion today is from Ms. Chandra. This question is also for Bu Egi. Ms. Chandra Suryani from Institut Teknologi Kalimantan to Dr. Pregi, that's what she wrote. I want to know, is there any finding in the cooling system that is more affordable to the independent fishermen?
Okay, the standard, the requirement of the cooling system, I think every product have a specific characteristic, like vegetable product, meat product, vaccine product maybe, they need special requirement that maybe is quite different one to another. So if we talk about the fish product, I think there is a special temperature to keep the freshness, like the temperature must be set under, maybe under 0 degree maybe, but I think that's it's very depend on the product. So we can say that the product must be the same treatment, but we have to look at more detail to the characteristic of this product. So we can design the cooling box not only for the temperature, but also we can design the size. So we can prediction the capability and also how the power that have to be provided. So the cooling box, the performance of the cooling box is good to keep the freshness and also to keep the quality of the fish product. I think this is, I hope this is answer your question. Ibu Chandra or Bapak Chandra?
Ibu Chandra.
Ibu Chandra, yeah. Sorry.
Yeah. Thank you, Ibu Egi, for the presentation, and also Dr. Hasima. Again, ladies and gentlemen, all of the plenary sessions already done, and to honor the speakers, we would like to give the e-certificate for the speaker. The first e-certificate goes to Dr. Hasima Jaafar from University Pendidikan Sultan Idris, Malaysia. Thank you very much for the presentation, Dr. Hasima. And the second certificate goes to Ibu Pregiwati Pusporini, PhD from Universitas Muhamadiyah, Gresik. Thank you for the presentation, Ibu Pregiwati. And And we'd like to invite the Vice Rector for Academic Affairs of Universitas Muhamadiyah Gresik to give his farewell speech for the two presenters. Dr. Hoirul Anwar, the time is yours.
Thank you very much for from Ms. Rohmi Husnia as the Master of Ceremony. On behalf of University of Muhamadiyah Gresik, thank you very much, Dr. Hasimah from University of Pendidikan Malaysia. Yeah. I think the title that you have already shared us are quite useful, especially on online learning and anticipation for this pandemic situation. So your experiences were quite useful and very beneficial for especially the teachers overall in the world. And second, I think to Dr. Prekiwati, I think the title was quite interesting as well, because that is sustainable change in food supply, and I think that also part of the solution, I think, as proposed by experiencing and also the practical analysis from the research. So thanks for both of you. I think we can also appreciate and hopefully can meet again for the next agenda the next year with a new research focus, and also has the contribution for the development of Indonesia as a whole, and in the development of knowledge as specific. So thank you very much, by the way, and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Bapak Dr. Hoirul Anwar. Alhamdulillah, all plenary sessions is done. Thank you very much for all honorable presenters and dear participants. And once again, we are so sorry for the unanswered questions because of the limited time. For the next session, will be handled again by the Master of Ceremony. Pak Chandra, the time is yours.
Thank you for all the keynote speakers, for the beneficial knowledge, and for the moderator that has finished her duty in delivering the sessions. Once again, I would like to inform to all of the presenters and participants, please join the whole agenda of this conference till the end of the program. Kepada seluruh presenter dan partisipan, dimohon untuk mengikuti keseluruhan acara dari awal sampai akhir sebagai persyaratan pengunduhan e-sertifikat di akhir acara. And for today, for the next sessions, the attendees are welcome to have a break, and we will start the parallel sessions from after the break at 13 p.m. by joining to a certain room based on your background knowledge through the guidance that has been sent to the participant email. Kepada seluruh presenter dan partisipan, untuk bidang ilmu ekonomi, teknik, hukum, dan kesehatan, setelah waktu istirahat pada pukul 13, disilakan untuk langsung bergabung di web pada masing-masing virtual room, seperti panduan yang sudah panitia kirimkan via email. Well, so see you later on pre-session, and wassalamualaikum warahmatullahi wabarakatuh.